Okay, welcome. We're going to start the second session of the patient day. I hope you're able to get a little something to eat. Just one quick thing. We have a live poll that's on the platform. So if you would go onto that, and they would like your live answers, and the answer to the question is, what hope means to you in one word? So there's just a little poll on there. So if you would go find that and answer what hope means to you in one word. Okay, I'm going to introduce Dr. Haley Ellis. She is a medical oncologist and clinical scientist specializing in cholangiocarcinoma at Massachusetts General Hospital, the Harvard Medical School in Boston, Massachusetts. She has a strong translational research background focused on resistance to targeted therapies, and she's previously trained at Dana-Farber Cancer Institute, Memorial Sloan Kettering Cancer Center, Washington University, and the University College Dublin. In addition to her clinical work and research, she is actively involved in a local cholangiocarcinoma awareness, research, and education care team. So you've heard us talk about the care teams, the local care teams. And thank you to Haley for doing that. She collaborates with a dedicated group of patient advocates to foster hope and establish connections and support within the New England community. Dr. Ellis is deeply committed and passionate about improving outcomes for patients with cholangiocarcinoma. And Dr. Ellis.
Thank you so much. Good afternoon, everyone. Thank you all for being here. We're so happy you're here. We really hope you're enjoying the first day of this conference, meeting each other, learning a lot, and feeling a lot of hope. So this next session is going to focus on the really important aspect of treating cholangiocarcinoma, which is the multidisciplinary team approach. So we have a fantastic panel of experts here today to talk to you about that. So first, I will invite them all up here. Dr. Kodali is a transplant hepatologist. Dr. El-Khoueiry is a medical oncologist. Dr. Sarwar is an interventional radiologist. And Dr. Jonathan Hernandez is a surgical oncologist. Okay, first up will be Dr. Kodali from Houston Methodist.
Thank you so much for having me, and thank you, Melinda, Stacy, and the Cholangiocarcinoma Foundation for giving me this opportunity to be here and speak about an area that I've been very involved over the last 5 years since I moved to Houston Methodist, and something that's very important for you all, and that's why you all are here today. I will get started with my slides. Sorry. So just quick introduction about myself. I'm Sudha Kodali. I'm a transplant hepatologist. I take care of people with liver problems. My area of interest is cholangiocarcinoma and hepatocellular carcinoma, the two liver cancers. And at Houston Methodist, we work very hard to advocate for and focus on transplantation as an option for patients with liver cancer. So this is a slide that I'm sure you've seen at some point, or you will see. This is a slide that focuses on the increased incidence but also mortality of cholangiocarcinoma worldwide. And over the last 10 to 15 years, we've seen an increase in the rise of these cancers arising from the bile ducts. Part of it is probably related to the fact that we have better imaging technology, better methods of diagnosing patients and treating them. And in the past, a lot of these cancers, especially intrahepatic cholangiocarcinomas, were categorized under biliary tract cancers. But now we know how to differentiate patients with liver cancers arising from the bile ducts, and we categorize them as intrahepatic, hilar, and distal cholangiocarcinomas. I'm going to focus a little bit on resection, but more on transplant for intrahepatic cholangiocarcinoma. Just a few slides about resection and outcomes for intrahepatic cholangiocarcinoma. As we heard yesterday from a lot of you during the dinner, patients who present with intrahepatic cholangiocarcinoma oftentimes may have large tumors, multiple tumors, and may have lymph nodes that are positive or have metastatic disease at the time of diagnosis. This is a sneaky disease, and a lot of times patients are asymptomatic. So because of all of these reasons, resection, which is just cutting out the tumor, may not be an option for about 50% of patients. And then when a patient actually presents to an oncologist, the treatment options, though, are much, much better now compared to maybe 5 years ago, are still not great. The overall 5-year survival based on multiple studies is anywhere from 22 to 44% in patients who've had resection, and majority of patients within 2 years will have recurrence, and that's what the data shows. There are some markers or predictors for poor prognosis, and one of them is vascular invasion, patients who present with metastatic disease, patients who have multiple tumors, and patients who have positive resection margins. We heard yesterday about patients who underwent resection or surgery, and R0 resection is what our surgeons usually aim for, but that may not be a possibility for everybody, and that affects the outcomes. So this is a study about 10 years old now from Parisa Tabrizian from New York, and they looked at 82 patients who had resection for intrahepatic cholangiocarcinoma, and patients who were followed along. Some of the factors that increased the risk of recurrence was, again, vascular invasion, satellite nodules, meaning a cancer with smaller nodules around the main tumor. These increase the risk of cancer coming back. And then, of course, there are other markers or predictors for survival for cholangiocarcinoma, especially when patients are being assessed for resection. And the stage of the cancer at presentation affects the outcomes for patients for most part. And of course, this is for resection, but also for patients who are not candidates for resection. The stage of presentation, whether it's T1 or T4, which is metastatic disease, affects their 5-year survival data, and that's really important to know. Now I'm going to focus majority of my talk on transplantation for intrahepatic cholangiocarcinoma. Just a disclaimer, I come from a center that strongly advocates for transplantation in patients who are eligible for intrahepatic cholangiocarcinoma who can get on the transplant list. I'm not making a statement here that all patients with cholangiocarcinoma will be able to get transplanted, but this is something that is oftentimes not discussed, and patients are oftentimes not aware of this being an option, and hence it's really important for you all to hear about this, especially outcomes in regards to transplant in patients with intrahepatic cholangiocarcinoma. This is a very important slide. This is by our own Dr. Juan Wale, who presented his findings in this paper back in 2015, where standard of care was gemcitabine. It was compared with gemcitabine with cisplatin, and patients showed improved progression-free survival and overall survival. And hence, since then, we've been using a combination approach. Of course, now we add immunotherapy agents to this regime, but using combination approach does improve outcomes, is what that landmark paper showed. Now, the recurrence-free survival for patients when you compare resection with transplant is very different. As you all can see on this slide here, hopefully I'm not going to lose my slides. So the upper part of the graph is patients who've been transplanted, and the lower graph is resection. And you can see that patients who get transplanted in the right setting do better than patients who get resection. Of course, what about neoadjuvant therapy? Is there a benefit to having neoadjuvant therapy before resection or transplantation? And yes, there is definite improvement in overall survival and recurrence-free survival in patients who are treated with neoadjuvant therapy before transplantation, but it's also true for patients who undergo resection. And these are the graphs that highlight that. Patients who receive neoadjuvant and adjuvant therapy do better when you talk about transplantation compared to patients who receive adjuvant therapy alone versus patients who do not receive any neoadjuvant or adjuvant therapy. And the same thing holds true for patients who undergo resection. The predictors for tumor recurrence and recurrence-free survival include multiple, but of course, we don't have head-to-head studies comparing transplant to resection because you need multiple centers doing transplantation, and you want to follow these patients prospectively to see how these patients do. But when you look at the size of the tumor, a lot of studies have shown that patients who have bigger tumors do poorly compared to patients who have smaller tumors. Tumor histology and extension, meaning patients who have vascular invasion and patients who have neural invasion do poorly compared to patients who have none of those features. And then, of course, the tumor size does play a role. When we talk about cholangiocarcinoma and patients that get transplanted, which I'm not going to cover today, because it's a very well-known indication for transplantation, and we have the Mayo protocol that most centers follow when it comes to transplanting patients with hilar cholangiocarcinoma. But when you look at the size by itself, tumors that are larger than 3 centimeters for hilar cholangiocarcinoma, and patients who have larger than 5 centimeter tumors for intrahepatic cholangiocarcinoma do poorly compared to patients who have smaller tumors. So these have been noted to be the predictors for tumor recurrence and improved survival if patient has better features on their surgical specimen or their explant pathology when we take the liver out after transplant and we look at the liver. Now, the first really, I think, important study in regards to transplantation in patients with cirrhosis for intrahepatic cholangiocarcinoma came from Gonzalo Sapisochin. This is from Toronto, Canada. Going in, the intention was not to transplant patients for intrahepatic cholangiocarcinoma. So they actually presumed or assumed that these patients had hepatocellular carcinoma. These were all cirrhotic patients that were transplanted. And after transplant, when the explant or the liver that was removed was looked under the microscope, the pathologist saw that about 48 patients from a huge number of patients that were transplanted at their center had intrahepatic cholangiocarcinoma. Now, they categorize these patients into 2 different categories based on the size of the tumor. Patients who had tumors less than 2 centimeters versus patients who had tumors larger than 2 centimeters. I'm standing here and saying 2 centimeters, what is that cutoff? But anyways, that was so many years ago, so I'm just going over the data. Because we've, over time, felt that we shouldn't restrict patients for transplant based on size alone. But anyways, going over the data, this study showed that patients who had larger tumors did not do as well as patients who had smaller tumors, that's less than 2 centimeters. And the other aspect that's shown in this slide is the overall survival was better for patients with smaller tumors compared to patients with tumors more than 2 centimeters. Again, incidental intrahepatic cholangiocarcinoma and mixed tumor. So yesterday we had 1 or 2 patients who shared that they had a combined tumor, which is hepatocellular carcinoma and cholangiocarcinoma. We call them mixed tumors or mixed hepatocellular cholangiocarcinoma tumors. So this study from DeMartin et al. In 2020 showed that there were various predictors for poor outcomes in patients who were transplanted for incidental cholangiocarcinoma. Of course, tumor differentiation was felt to be one of the predictors, meaning patients who had poorly differentiated tumors or mixed tumors did poorly compared to patients who had well-differentiated intrahepatic cholangiocarcinoma. And this study looked at a benefit of having neoadjuvant therapies. So if a patient who is undergoing resection or transplantation, and this is the same kind of similar concept that I showed in prior slides, if a patient receives neoadjuvant therapy, whether it's systemic therapy in combination with local regional therapy like TACE or Y90, or radiation therapy, those patients do much better than patients who receive maybe one modality versus none. So that's very important to highlight, and we increasingly use a multidisciplinary approach where we combine different options of treatment for patients with large intrahepatic cholangiocarcinomas so that we get good response and then are able to see if these patients can get to resection or to transplantation. This is a paper from our center. Dr. Connor, who's one of my surgical colleagues, put out a review paper, and this table summarizes all the studies that have been published over the last 10 years that have looked at intrahepatic cholangiocarcinoma patients that were transplanted incidentally. Again, intention going in was not to transplant a patient. They didn't know that the patients had intrahepatic cholangiocarcinoma, but after the transplant was done, it was noted that their tumors were intrahepatic rather than hepatocellular carcinoma. And you can see right here, the overall 1, 3, and 5-year survival rates are all over the place, ranging anywhere from 30% to 50 to 60%. This table shows patients who knew going into the operating room that they had intrahepatic cholangiocarcinoma. And again, the idea is to highlight on this area here, the 5-year overall survival rates are anywhere from 25 to 80% in patients who are transplanted for intrahepatic cholangiocarcinoma. I'd like to highlight that the number here, the 80%, is actually from our center, but this was a very small series of 5 patients that were carefully selected and transplanted, and all 6 of them did really great for the first 3 years, and 1 passed away with the disease and recurrence. And so 85% 5-year survival was unheard of course, again, being a small 6-patient study. There was a meta-analysis that was published for patients who underwent liver transplantation for intrahepatic cholangiocarcinoma. And as you can see here, the pooled 1, 3, 5-year overall survival was actually pretty decent, 42% for this group. Just note that only 7 studies had patients that had bigger tumors. So as you transplant patients with larger tumors, over time, even if you monitor these patients very closely, the survival is not going to be as great as patients who get transplanted for, say, smaller tumors. So the conclusions were small tumors have better outcomes compared to larger advanced tumors, and neoadjuvant therapy is beneficial and definitely recommended for patients if they are undergoing resection or transplantation. So I'd like to focus a little bit on what we do at Houston Methodist. So about 8 years ago, Dr. Milind Javle, that you all know of, he's a pioneer and a world expert in intrahepatic cholangiocarcinoma. We're very fortunate to have them right across the street. So Methodist is where I work, and MD Anderson sat and came up with this protocol for neoadjuvant chemotherapy. So any patient with intrahepatic cholangiocarcinoma, irrespective of the number and size of tumors, as long as the disease was limited to the liver with no nodal disease and no vascular invasion, those patients were initially deemed to be eligible for transplantation if they were felt to be not resection candidates. Again, if a patient could get resection, they would get resection, but these patients had been declined at other centers for surgery or transplant, were seen by either our oncologist or oncologist at MD Anderson, and they were on systemic therapy and were monitored very closely for about 6 months. And if their cancer did not worsen or their cancer did not progress and they still had liver-limited disease, we went ahead and evaluated them for transplant, and we transplanted those patients. I'm going to skip this slide for the interest of time. So this is our first publication showing the 6 patients that we transplanted. As you can see here, all of these patients had huge tumors, multiple tumors, and some patients actually had resection, and then they recurred. So these patients were seen at other centers and deemed non-resectable and were continuing on chemotherapy, and we saw these patients, put them on our protocol, and got them transplanted. And this is our paper that shows that the overall survival and the recurrence-free survival graphs are much better than what you've seen so far. Fast forward 4 years later, we had evaluated about 65 patients, and this is our next paper that we published in 2022. So out of the 65 patients that were referred to us, about 37 patients were listed for transplantation. And of course, on the right side, you can see the reasons for patients being declined. Extrahepatic disease, patients who actually could be resected by our surgeons. We didn't want them to go through the process of transplant, so they got resected. But otherwise, of the 37 patients that were listed for transplantation, 18 got transplanted at the time of this publication, 14 were not transplanted, 7 were still waiting on the list, and I will share the results. So you can see here, highlighted in these boxes, these patients had tumors ranging anywhere from 3 centimeters to 20 centimeters, with a median tumor size of 10 centimeters. So we did not decline patients based on the size of the tumor by itself. Patients had poorly differentiated cancer, which we know is a prognostic indicator for high risk of recurrence. And then patients had systemic therapy. All of them had to be on systemic therapy. Some had resection. Some also had TACE or Y90 to control their tumor. And this is the overall survival for patients who had transplanted. So this is the 18-patient data, where you can see that compared to patients who were transplanted, who had a 5-year 57% survival, the patients who actually could not get transplanted, some were still waiting on the list. That's why the list doesn't go, the red bar doesn't go down or doesn't keep going forward. But the outcomes are not as great for patients who are not eligible for transplant, at least based on our cohort of patients. And again, tumor characteristics, big tumors, aggressive tumors. We transplanted patients that were declined at other centers. Of course, of the 18 patients that were transplanted, 7 recurred. We know that recurrence is common in spite of very intense surveillance protocols. And 3 of them had lung lesions or lung recurrence, peritoneal recurrence, bone mets, et cetera. And of course, these patients go on chemotherapy post-transplant and follow up with oncology on a very close, regular follow-up basis. So these patients were treated with chemotherapy or radiation treatment as needed for these recurrence. I'm just going to quickly highlight the fact that you've seen this part of the slide. This is the MD Anderson data. So Dr. Javle was kind enough to share their center's data, and I presented this in our International Liver Transplant Conference a couple of years ago. And these were stage 1 and 2, so not very advanced compared to what we, I guess, deem based on the size. And the 5-year survival was 15% for these patients who were not resected or transplanted and were on systemic therapy. So again, a clear difference, but not a good comparison because these were not randomized to transplant versus not. Of all the different options that are out there, transplant does offer better survival outcomes. Of course, we need larger centers and multi-center studies to kind of help us gain more insight and gather more data. And in the interest of time, I'm just going to share that this is, again, mutational profiling information that we all now really rely on. And we are looking at post-transplant patients and monitoring their circulating tumor DNA, but also biopsying recurrent tumors and looking at their profiling information to see actionable mutations so that we can tailor therapy for these patients. Survival after transplantation, there are some mutations that are favorable versus some that are not. So we are, again, looking at some of that data for our intrahepatic, hilar, and mixed tumor patients. And as we gather and gain more data, we hope that we continue to transplant patients who meet criteria for transplant with large intrahepatic tumors and utilize biomarkers, molecular profiling information, et cetera, to improve the overall survival for these patients. So in conclusion, size should not be a cutoff. When you look at patients that probably would benefit from transplantation, tumor biology is more important than size, is what we feel. And hence, utilizing all the information in the pre-transplant setting, neoadjuvant with combination of systemic, loco-regional therapies and radiation to downsize and downgrade a tumor, and then see if a patient gets resection eligible versus transplant eligible has been our approach. And we continue to work with MD Anderson, and we continue to share our data at meetings and conferences like this so that not only providers, physicians, nurse practitioners, but patients and caregivers also know that liver transplantation remains an option for patients who have intrahepatic cholangiocarcinoma. And that's my talk. Thank you so much for the opportunity. I really appreciate it. Thank you.
Thank you so much, Dr. Kodali, for that fascinating talk and for your pioneering work in increasing eligibility for patients with cholangiocarcinoma to be eligible for transplant. I'm now happy to introduce Dr. El-Khoueiry. He is an associate professor of medicine at the University of Southern California and associate director for clinical research at the Norris Comprehensive Cancer Center in Los Angeles. As a member of the GI oncology section, he oversees the hepatobiliary cancer research program. He's also medical director of the Clinical Investigations Support Office and chief of section of developmental therapeutics and phase 1 program. He's a member of the NCI Hepatobiliary Cancers Task Force and co-chair of the Hepatobiliary Cancers Subcommittee of the Southwest Oncology Group. He has led several trials evaluating targeted therapies and novel immune oncology agents for hepatobiliary cancers. As a member of the Stand Up to Cancer Epigenetics Dream Team, he's evaluating the impact of epigenetic drugs on the immune microenvironment in hepatobiliary and pancreatic cancers. He's also involved in multiple research efforts focused on biomarker development for hepatobiliary cancers, and he's the recipient of the Clinical Investigator Team Leadership Award from the National Cancer Institute. Thank you so much, Dr. El-Khoueiry.
Thank you, Haley, for the kind introduction. It's always an honor to be here and to speak to a room full of patients and caregivers. I've been in this field for a long time. I'm not going to date myself, but certainly over 15 years. And I've seen it come a long way. And the development in this field has certainly accelerated over the past 10 years. And I have to say that in large proportion, thanks to the efforts of the Cholangiocarcinoma Foundations and many of you as well, working with us hand in hand to advance the field. So today I'll be speaking about systemic therapy for cholangiocarcinoma, meaning covering chemotherapy, immunotherapy, and targeted therapy. Well, luckily there's a lot of development in the field, so it's very hard to cram all of this in 20 minutes. So I'm gonna try my best to hit major topics, and we can have questions or talk offline later. First, let's set the stage. When and where is systemic therapy used for cholangiocarcinoma? The most common setting to use systemic therapy is metastatic disease or locally advanced that cannot be resected. However, as you heard, we now use it in the neoadjuvant setting before resection or before transplant. That role is evolving, and there's limited data but rising interest. We do use it in the adjuvant setting after resection. There, the goal is to lower risk of recurrence. We need to do better in that space. However, today, we will focus mostly on metastatic and locally advanced resectable settings. So let's start with what we call first-line treatment, meaning when patients first present with advanced disease, how do we treat cholangiocarcinoma? You already saw this slide that the combination of gemcitabine and cisplatin and 2 chemotherapy drugs had become the standard and remained the standard for a long time until we were able to make an advance. And I'm gonna go to that straight now. So the first attempt was to try and intensify the chemotherapy. So how about if we added a third drug with gemcitabine, cisplatin, and nab-paclitaxel? This was a SWOG, Southwest Oncology Group study led by Dr. Schroff. And even though numerically there was a small difference in the median survival with the 3 drugs versus the 2, 14 versus 12.7 months, this did not reach statistical significance, meaning it could have happened by chance. So it didn't lead to this triplet becoming a standard of care. However, we did learn something from this. When we looked at subgroups of patients, it did appear that patients who had locally advanced non-metastatic disease seemed to really benefit more, had longer overall survival with the triplet versus the 2 chemotherapy drugs, and had a higher response rate with the triplet versus the 2. So based on that, there is a hypothesis now that this triplet may be beneficial in that locally advanced setting, and some studies are evolving in that space. The other attempt was to do better by combining the 2 chemotherapy drugs with immunotherapy targeting PD-1 or PD-L1. The way I explain this, and some of you or many of you are familiar with this, the immune system knows how to hide, the cancer knows how to hide from the immune system. So when we use the traditional checkpoint inhibitors like anti-PD-1 and PD-L1 therapy, we're trying to unmask the tumor and have the immune system recognize the cancer as something foreign that should be attacked. So the good news is there are now 2 studies that have shown that adding an anti-PD-1 or PD-L1 drug to the chemotherapy backbone improves survival. So both of studies adding gemcitabine cisplatin with durvalumab or gemcitabine cisplatin with pembrolizumab showed an improvement in survival. And you see here what we like to look at rather than the average numbers, the medians, is what's called the hazard ratio. And you see that the hazard ratio here is around 0.75 to 0.8, which means 20 to 25% reduction in the risk of death with the addition of the immunotherapy. And that benefit seems to be long-lasting. You see these curves in the graph on the right of the slide. Those curves remain separated for an extended period of time, meaning the benefit is durable. This is more details about some of these studies, which I'm not going to go into, but the improvement was not just in overall survival, it was also in progression-free survival and response rate with both studies. So how can we do better than this? Well, we can do better thanks to what's happening in the room next door with the basic science track, right? Understanding what's happening in the tumor itself. And we've learned over time that cholangiocarcinoma is a very desmoplastic tumor, meaning it has a lot of scarring, a lot of fibrosis, which does a lot of things in the tumor, including impede the access of chemotherapy drugs to the tumor, but also impedes the activity of immunotherapy agents for many reasons. In addition to this fibrosis, cholangiocarcinoma has a lot of cells that fight against the immune system attacking the cancer. So these include things like tumor-associated macrophages, myeloid-derived suppressor cells, etc. So part of the strategy going forward is to try and stimulate the immune system from multiple angles, not only with anti-PD-1 and PD-L1 therapy. I'll give you a few examples of this. Another thing to keep in mind is that, and you've heard this before, this is a heterogeneous disease, not only by location, meaning where it started, but also at the molecular level. There are different mutations that may impact the immune system and how it behaves against the cancer. So when we use PD-1 or PD-L1 therapy alone, we're really only activating the T cells that are right there in the immune microenvironment around the tumor. And they have to be a specific subtype of T cells. So how do we do better than this? There are multiple strategies, and I'm not going to spend too much time on this slide, but I'm going to show you one strategy that has been tested in the clinic, which is really to target something called VEGF, vascular endothelial growth factor, which when you target this, you actually inhibit multiple things around the tumor that allow the influx of immune cells to the tumor area, increases oxygenation, and changes the makeup of the immune cell around the tumor from pro-tumor to anti-tumor. So we tested this concept in a study where we gave patients the chemotherapy, gemcitabine cisplatin, with a combination of atezolizumab, an anti-PD-L1, and bevacizumab, an anti-VEGF drug, versus the chemo with anti-PD-L1, atezo, and placebo. So really trying to decipher the benefit of adding the anti-VEGF therapy. Now, this was a small study. It was not really powered to compare the two arms directly, but rather to test the benefit from each arm compared to historical data. And the primary endpoint was progression-free survival. And when we look at that, you see that the curve in blue, which is the curve with the addition of the bevacizumab, the anti-VEGF drug, showed an improvement in progression-free survival with a hazard ratio of 0.7, which means 0.67, a 33% reduction in the risk of progression with the addition of the bevacizumab. And that benefit seemed to be lasting at 6 and 12 months and even close to 18 months. Now, there was no difference in overall survival, but the study was not powered to actually detect a difference in overall survival. So this was good at hypothesis generating, maybe something to build on. We also did notice that despite no difference in response rate, that patients who got the bevacizumab had longer duration of response. We took this a bit further and tried to figure out, is there a subset of patients who may benefit from this therapy? And consistent with our hypothesis, we found a couple of things. One, if there was a higher expression of this vascular endothelial growth factor, and if the tumor was high in what we call hepatocyte-like cells, those tumors tended to have more benefit from the addition of the bevacizumab. So that's good. Now, it's not easy to test these tumors up front at this point for these things and select patients for this therapy. So we're working on maybe a test that would be easier to deploy into the clinic so we can study this a bit further. Okay, what about other potential improvements? Remember, this is it's supposed to be a depiction of the T cell. And on the right of the T cell are the brakes that we want to remove, and on the left are the gas pedals, where if you actually stimulate those receptors, the cell will become more active. So there are studies going on both sides of the T cell to either remove brakes or step on the gas pedal. I will show some examples here. These studies that have recently launched. So this is a study looking at an agent that targets two breaks, both PD-1 and CTLA-4. And then there is another arm in the study that looks at an agent that also removes two breaks, PD-1 and TIGIT. So these studies are currently in the clinic being tested. And this is the overall design, so I'm going to skip through that. Another example that I want to show of something that's coming up is in a second-generation CTLA-4 inhibitor called botensilimab, which really is a more potent drug than the first-generation CTLA-4 antibodies for multiple reasons. It's much better at stimulating the immune system and turning these tumors that don't have a lot of immune cells into tumors that may tend to respond to immunotherapy. So when we did the study in all solid tumors with this drug, it used to be called Agent 1181, we did notice that it could work in multiple tumor types, including tumors that don't regularly or normally respond to immunotherapy. So based on that, there's been more studies going on in this space, and hopefully we'll be launching a study in cholangiocarcinoma in the near future. Great. I covered now what we call first-line therapy. So what happens when a patient benefits from first-line for a while, but then the tumor becomes resistant? What do we do in second line and beyond? So the standard of care is still actually this combination chemo called FOLFOX, which is 5-FU and oxaliplatin. And this study compared FOLFOX to just best supportive care. And you see there was a modest benefit from FOLFOX versus best supportive care. It's not a home run, but it was better than doing nothing. And this is what we go to, unless the patient is a candidate for a clinical trial, where that would be the preference. We still use FOLFOX at some point in the journey, but certainly we try to prioritize clinical trials. Another thing that's emerging is using irinotecan, or a novel version of this drug called irinotecan. It's called liposomal irinotecan, which is much better at penetrating into the tumor bed. There's a study from Korea, this is the NIFTY trial that I'm showing here, that showed a potential benefit from this combination of 5-FU with liposomal irinotecan called El-Khoueiry versus 5-FU alone. So the PFS went from 1.7 to 4.2 months, and the overall survival from 5.3 to 8.6 months. But this was the data from Korea. Data from Germany did not show the same outcome. So, we don't have a definitive evidence now that this is certainly beneficial. There may be subsets of patients who may benefit. Another development is to try and incorporate novel agents with chemotherapy in second line. So CTX-009 is what we call a bispecific antibody. So you can see in the schema on the left upper corner that this antibody targets VEGF, which we talked about earlier, and something called DLL4, which is part of the Notch pathway in these tumor cells, and is very important for how the immune system responds, but also for how the tumor maintains its vasculature, etc. When this drug was combined with chemotherapy in a small study, the combination had a response rate of almost 38% in cholangiocarcinoma after first-line therapy. So this was quite intriguing and promising. So thanks to that initial result, now this has gone to what we call a phase 2/3 study that's ongoing in the United States. Compass, the company that sponsors the study, actually has a booth outside, and so they are here actually and participating in the meeting as well. How about targeted therapies? This is kind of the last portion of my talk. As many of you know, this is a disease where you see different mutations in a subset of patients. Globally, we like to think that up to 35% of patients with cholangiocarcinoma have what we call an actionable mutation, a mutation that we can do something about. And that varies as to where the location of the primary tumor is. Is it in the liver, intrahepatic, extrahepatic, or gallbladder? And the type of mutation varies by location as well. So there is now a significant number of therapies that target different genes. The most common ones that we should be talking about here for cholangiocarcinoma are FGFR2, IDH1, HER2, BRAF. In green, I highlighted the ones that have some sort of regulatory approval, either accelerated approval from the FDA or full approval. The latest one is trastuzumab deruxtecan, which recently got approval across solid tumors that have HER2 expression. And these we currently use for patients with cholangiocarcinoma who have these relevant mutations. Of course, the problem here is that patients develop resistance, and we are trying to look at combinations and novel drugs to target these pathways in multiple ways to improve the outcomes further. Now, how about can we look at more targets than just these 4 that I showed you? And yes, so one of the targets there's a lot of research on is KRAS, which is actually mutated in up to 20 to 25% of cholangiocarcinoma patients. This is one of the drugs being studied in this space called adagrasib, and you see a response rate of 42% in a very small group of patients here nonetheless, but it is promising, intriguing, and hopefully will be built on further. Another approach is to target other proteins that are relevant to this KRAS biology. This is one called PLK1, and that's been shown in other tumor types, including colon cancer and pancreatic cancer, that if you inhibit PLK1 at the same time as giving chemotherapy in patients with KRAS mutations with colon or pancreatic cancer, you actually get great synergy. So thanks to that, we are about to launch a trial in SWOG, the Southwest Oncology Group, where we're going to give chemotherapy with or without this PLK1 inhibitor called onvansertib in cholangiocarcinoma. Lastly, I mentioned that these mutations can change how the immune system responds and how it's active or not active. And for example, with IDH1, targeting IDH1 works better if you have actually a competent or active immune system. And I'm gonna here oversimplify the science because I have limited time and tell you that there was enough evidence from preclinical work to combine a drug targeting IDH1, ivosidenib, with immunotherapy and study that in the clinic, and that study is ongoing. Another emerging target that's very important in cholangiocarcinoma is actually p53. But p53 is commonly mutated in cholangiocarcinoma. There is a subset of patients who have wild-type p53, but have actually amplifications in MDM2, which shuts off p53 and makes the tumor act like it is as if it's lost p53. So there are now drugs that target MDM2, and there's actually ample evidence from data that suggests that MDM2 amplification is a bad prognostic marker in cholangiocarcinoma that's associated with shorter survival. And there's actually a drug right now that, here I have the numbers and letters for it, BI 907828, which is an MDM2 p53 antagonist that's actually in the clinic. And that in initial small studies showed a benefit in cholangiocarcinoma. You see here 8 patients with biliary tract cancer were treated, 4 with monotherapy, 4 with combination, but 5 patients actually had a partial response. So that led to a phase 2 trial called Brightline 2 in patients with multiple tumor types, including cholangiocarcinoma. So, in summary, biliary tract cancers or cholangiocarcinoma continues to present a therapeutic challenge because of its heterogeneity, this desmoplastic reaction and fibrosis, the immune suppressive microenvironment, but we have made major progress. We have a new first-line standard with chemo and immunotherapy. We have multiple targeted therapies approved and coming on board. We are actively looking at novel approaches to harness the immune system in multiple different ways and expand the number of mutations or alterations that we can actually go after with specific drugs. So thank you for your attention. Thank you for the Cholangiocarcinoma Foundation for their advocacy, their support of science, the creation of this amazing community of researchers, patients, and advocates. And for our patients, for the courage to engage and participate in clinical trials and research. And we look forward for more advances in this field. Thank you very much.
Thank you so much for that incredible overview. It's really amazing to see how much progress has been made since 2010 and how many therapies we have available for patients with cholangiocarcinoma now and how many more even in the pipeline. Very exciting. So now I'd like to welcome Dr. Sarwar, my colleague from Boston. He is an associate professor of radiology at Harvard Medical School and an interventional radiologist at Beth Israel Deaconess Medical Center in Boston. He performs all types of vascular and non-vascular, minimally invasive procedures with a focus on interventional oncology and hepatobiliary interventions. He's a principal investigator of 2 prospective clinical trials of radioembolization for hepatocellular carcinoma and cholangiocarcinoma, and he is also co-director of the Beth Israel Liver Tumor Multidisciplinary Program. Thank you.
Thank you, Haley, for that kind introduction, and I really appreciate the invitation to speak at this conference. So I'll be talking about local regional therapies for cholangiocarcinoma. One of the things I'll mention from the session this morning is that I feel while I'll be focusing more on cancer-killing therapies, I think one of the areas where interventional radiologists can provide tremendous values is managing biliary tract disease with biliary catheters. I know that's a big challenge. Unfortunately, I'm not going to be speaking about that today, but something for the future. These are my disclosures. So just starting quickly with anatomy, I think from an interventional radiology standpoint, it's really important to know that the primary type of biliary tract cancer that we treat is the mass-forming type that you can see in the upper left corner. We do treat patients who have extrahepatic biliary tract cancer or who have gallbladder cancer, but typically that's only in the case when there's a tumor in the liver which can actually be targeted. Usually it's difficult for us to target tumors that are solely sitting in the bile duct. So in terms of treatment strategies and guidelines, I think looking at the NCCN guidelines that were recently shown, I think primarily, obviously, the first step that we would ideally want for most patients to have is to get a resection or a surgical resection. But then I think IR therapies start to get introduced in the guidelines when we talk about unresectable or metastatic disease. I think one category that I find really important is the borderline resectable patients. These are patients who are not initially resectable, either because their tumor's right at the margin and the surgeon's worried that they're not going to get a clean margin, or because after they cut out the part of the liver that contains the tumor, the remaining liver's not big enough, in which case they can't do surgeries. And that's an area where a good interventional radiologist can really make a huge difference. So when we think about kind of treatment paradigms at our center in terms of performing IR therapies in patients, there's certain roles for patients in all 3 stages, in resectable, unresectable, / borderline resectable, as well as metastatic disease. And as I go through the slides, I'll touch base on each of these. One of the important things that I'll mention is that, and I apologize, I feel, okay, just on my TV screen, the slides are cut off, but the first question we ask usually for patients is that whether the disease is resectable or not. And the reason for that is because if the disease is resectable, then the median survival is close to 4 or 5 years. Whereas if the disease is not resectable, then the survival can be much lower. And I think proceeding with surgery with curative intent is really the first goal, but there are ways that an IR can help. When we think about the goals of surgical resection, one of the highlights or the key things that a surgeon is looking for is that when they do a resection, will they get negative margins? Will they be at least 5 millimeters or a centimeter from the resection margin to any viable tumor? And so the factors that determine unresectability, and I know Dr. Hernandez will probably touch on these in his talk, is involvement of the surgical margin, which is typically the falciform ligament or the middle hepatic vein, the future liver remnant, the amount of liver that's going to get left behind, and if you're non-cirrhotic, then you will need at least 25% of your liver. If you've had chemotherapy or systemic therapy in the past, or you have fatty liver disease, then it's about 35%, and if you're cirrhotic, then you need at least 40% of your liver left behind. And these are areas where IR can help in trying to augment the remaining liver so that surgical resection is possible. So let's start talking a little bit about the therapies that we have available. So we'll start with thermal ablation. So tumor ablation is the administration of cytotoxic injury to tumor cells via the injection of chemical or energy changes in temperature. Most commonly, this is done with energy changes with temperature. So under ultrasound guidance, the patient's lying on on a CT scanner or on a table. We'll find a tumor, we'll put a needle into the tumor, attach it to a machine, and burn the area. And the goal is to kill all the tumor cells in the tumor, but also have a margin of normal tissue, not unlike surgical resection. And while we're doing this, we're trying to limit the damage to the non-tumoral structures. These are typically needle-based therapies. The two most common ones are known as radiofrequency ablation and microwave ablation. These both cause injury by basically heating up the tissue to a large degree. Ethanol ablation, which is a chemical ablation, has fallen out of favor because it's very non-uniform, although it is quite cheap, but it's also less effective because it's non-uniform. So when we do thermal ablation in patients, and usually this is only done in patients with less than 3 centimeter tumors, which unfortunately in cholangiocarcinoma is not very common because there's no common ways to screen for this type of disease, and most patients get diagnosed with greater than 3 centimeter tumors. But if you're lucky enough to have a tumor that is less than 3 centimeters, then this rad path analysis basically shows that the thermal ablation will cause a white zone of coagulated tissue, which is cell death. And when these patients get surgical resection and they're sent to pathology, often they won't find any living viable cells if the ablation is well done and if it's done with a large enough margin. And then there's a red zone around it which may have partial necrosis or inflammation, which is why we want to make sure when we're doing the procedure that we get a really large margin around the tumor. So the concept of the ablative margin is important because there's known microscopic extension of the tumor beyond the apparent margin of the tumor that we see on CT or MRI into normal appearing tissue. And so for HCC, for example, it used to be that we used to think, say, hey, 5 millimeters of a margin is enough. Then it was 5 to 10 millimeters. And now pretty much for all tumors, we try to get at least a centimeter margin, very similar to our surgical colleagues. Incomplete margins on early imaging usually mean that there's going to be some tumor recurrence down the line. And then we're thinking more and more about looking at the margin not just in one plane, but in all 3 planes. And that's led to a concept known as ablation mapping, which is being used at advanced centers to make sure that we get that circumferential margin around these tumors. So who is a candidate for thermal ablation? First of all, I would say that somebody who's not a surgical candidate, either because of age or because of the lack of a future liver remnant or because they've had surgery before. Usually this is best evaluated in a multidisciplinary tumor board, and I think getting a referral to a center that has one of those tumor boards with an interventional radiologist is really important. And then one category of patients is patients who receive this treatment as a primary treatment. So you've been diagnosed for the first time with a cholangiocarcinoma, you have a less than 3 centimeter tumor, there's no extrahepatic spread, and you're not a surgical candidate. So the median overall survival for patients who underwent ablation in multiple studies that have been published was more than 2 years, and the progression-free survival was more than 3 years in this setting. Another candidate for thermal ablation is, again, patients not a surgical candidate evaluated in a multidisciplinary tumor board who are being treated for recurrence. So you had an initial resection or you had systemic therapy, there's no extrahepatic disease in general, or even a small amount of extrahepatic disease, but you now have a less than 3 centimeter tumor, 1 or 2, not more than that, within the liver. I think in those patients as well, this study that was published in 2011 showed that there was, first of all, it showed that there was no difference in, let me just go back. It showed that there was no difference in survival in this upper graph between patients who got a repeat resection compared to a thermal ablation. So there was no difference in survival, but the patients who received a thermal ablation had less morbidity. They left the hospital sooner and they did better in terms of complications and other morbidity. In the lower graph, we see that the patients who had larger than 3 centimeter tumors did better with surgery compared to thermal ablation, which is why we use that 3 centimeter cutoff when selecting patients for thermal ablation. However, the reality is that most patients, because of the size of the disease, because of its insidious nature, are generally not candidates for thermal ablation, but it's a good option to be aware of in case you are one of those patients. So the next therapy to talk about is transarterial chemoembolization. The rationale for intraarterial therapy, specifically for tumors in the liver, is because in the normal liver, the hepatic artery supplies 25% of the blood flow, and 75% of the blood flow is coming from the portal vein, another big vessel. But in tumors, the majority of the nutrients for the tumor comes from the hepatic artery, and a very small component comes from the portal vein. So interventional radiology takes advantage of this by providing therapy through the arteries. So chemoembolization is the combination of infusion of concentrated doses of chemotherapeutic drugs and some form of hepatic artery embolization, meaning that we block the blood supply. We basically put in a lot of chemotherapy and then we block the blood supply, which provides with highly localized drug delivery. This has several advantages. First of all, there's high first pass extraction, meaning that the first time that the tumor gets bathed with the chemotherapy, the tumor pulls in a lot more chemotherapy than if it's just systemically given. It also increases the contact time with the tumor because after we put the chemotherapy in, we shut the blood flow off so that nothing's coming in to wash the drug out. This also leads to reduced systemic toxicity. One of the things to be aware of, and most interventional radiologists, almost all of them are aware of this, is that there's slightly higher risk of biliary sepsis in patients with stents if you're blocking the blood supply of the liver, but that can easily be controlled if you just give some pre-procedure antibiotics, which most of us do. The most common way of doing chemoembolization is a conventional TACE, in which we use iodized oil, ethiodol or lepiodol, which is a poppy seed oil. It accumulates in HCCs and intrahepatic cholangiocarcinoma. The oil acts both as a drug carrier as well as a tumor-seeking and an embolic agent. It causes occlusion of the hepatic arterioles, the fine branches of the tumor, up to 30 microns, and it actually goes over to the portal venular side as well and basically bathes that tumor in chemotherapy. However, despite there being multiple studies looking at many different drug types, at their effect in intrahepatic cholangiocarcinoma, as well as multiple different forms of chemoembolics, the median survival for most patients who were undergoing this therapy was about on the order of 10 to 12 months. So similar to systemic therapy, but not much greater than that. And this had to obviously be only, these studies were done in patients who did not have any disease outside the liver. All of the disease had to be inside the liver. So in general, what we know about chemoembolization is that yes, it has an effect. However, the effect is not tremendous. And patients who get a chemoembolization and get downstage, first of all, the percentage of those patients is very low. But when those tumors are resected, there's a lot of viable tissue that's left behind after chemoembolization. So mostly chemoembolization is considered to be a palliative therapy rather than a curative therapy the way thermal ablation is. Which brings us to transarterial radioembolization, which is a little bit of a newer technique and has some promising data that I'd like to share. So what is radioembolization? It's also known as SIRT, or selective internal radiation therapy, Y90, or radioactive beads. It's a radiation therapy and combined embolization to hepatic malignancies, and we basically rely on the blood supply to make sure that these microspheres that are labeled with lethal radiation land only in the tumor and go nowhere else. This is kind of what an electron micrograph of this device looks like. They're 32 microns in diameter. Yttrium-90, which is the radioactive agent, is bound permanently. The half-life is about 64 hours, so you're not radioactive for a long period of time. And the best part is that the penetration is anywhere from 2 millimeters to 11 millimeters from where the beads land. So what that means, if you think about it, is that, for example, compared to external beam radiation, where we have to be very careful, we're giving 50 centigray in 5 or 6 fractions. In radioembolization, I typically give 400 grays in a single session because we can give about 3 orders of magnitude more radiation because we know it's all going to be focused precisely on the tumor. They get stuck in the liver tumor vessels, which are about 25 to 75 microns, and then keep radiating the tumor over the next 2 to 3 weeks. There's 2 products out there, TheraSpheres and SIRSpheres, glass and resin microspheres. Depending on the interventional radiologist you approach, everybody has their own preference, but they act pretty much in the same way. So there's 2 steps to radioembolization: a planning procedure in which we make sure that the hepatic arterial vasculature is very amenable to doing a radioembolization, and then the treatment procedure where we infuse the beads through a catheter that's placed in the branch that's only supplying the tumor and not the normal liver or anything else. These 2 procedures can be done on different days, but in some centers like ours where people come from long distances, we typically do a same-day procedure where you get the planning and the treatment on the same day. So where do transarterial therapies fit in? For resectable intrahepatic cholangiocarcinoma that's borderline, that's not clearly easily resectable, and that's a determination that's made by the surgeon, we like to perform radioembolization or transarterial therapies for neoadjuvant therapies. We also try to convert patients who are borderline resectable into resectable patients using these treatments. For patients who are unresectable but only have disease within the liver, it can be used in first line prior to starting systemic therapy. It can be used in the salvage setting after there's been failure of multiple lines of systemic therapy, or something that's happening increasingly in trials right now, and there's a trial running at Beth Israel that I'll talk about, you can combine it with systemic therapy to get some of that synergy where the Y90 primes the immune system, and then this immunotherapy starts to act as well. There's no comparative studies between chemoembolization and radioembolization, but there are some advantages to radioembolization in that it is thought to be safer. The choice is mostly dependent on operator or institution preferences, but most recent reports have started to use radioembolization because the effects have been so good. In this study that was published in 2021, the main difference that was seen between chemoembolization and radioembolization was that radioembolization had a better side effect profile than chemoembolization. So just skipping, sorry. So here in the chemorefractory setting, this is where radioembolization first started. And basically this showed that patients who had had multiple lines of systemic therapy, basically there were multiple studies that showed that patients had a survival after they had no systemic therapy options of anywhere from 10 months to 25 months by getting radioembolization. Unfortunately, these patients had to be selected so that they only had disease in the liver. If you had disease outside the liver, then it becomes more challenging to just treat you with radioembolization after you've failed systemic therapy. One of the things that we found from the studies that is important is dosimetry. So partition model dosimetry, which gives that 400 gray of radiation dose that I'm talking about, that really high radiation dose, tended to be more effective and lead to a survival advantage compared to patients who got BSA dosimetry, which gives a lower amount of radiation. So from 2010 to almost 2020, most of the studies, a lot of centers around the world, this is from Europe, the US, a lot of centers started to use radioembolization more and more frequently in patients with liver-dominant disease. However, one of the things that we found was that when the percentage of patients who were getting Y90 up front, meaning that patients who were just getting the Y90 in the salvage setting, even though some of the survival data was really good, more than 20 months, 40 months in this study, but some patients would not do so well because they had been maxed out on the systemic therapy or because their liver couldn't tolerate very high doses of radiation. So in more recent years, in the radioembolization or the interventional radiology community, most centers, and this is just 4 studies, but since then there's been many more, most patients are, like in centers that do high quality radioembolization, the patients are getting radioembolization up front, and that's leading to some better outcomes and more patients who are getting surgical resection who were not initially candidates for surgical resection. This is a study that we showed at the Cholangiocarcinoma Foundation last year and is in the process of getting published, but it basically showed that there was an advantage in progression-free survival in patients who got Y90 first and then got systemic therapy for liver-only disease compared to patients who got systemic therapy first and then went on to radioembolization. So briefly in summary, the older studies started to do a lot of radioembolization in the salvage setting and the second line setting. The newer studies are starting to do radioembolization up front and then moving on to systemic therapy. One of the important things, I only have 2 minutes, so I'll try to rush through these, but one of the important things to talk about is that cholangiocarcinoma is typically diagnosed as large tumors. Only 30% are diagnosed at a resectable stage, only 12% in the Sudha registry. Anatomical resection, which is something I'm sure Dr. Hernandez will talk about, is associated with improved survival, but 50 to 70% of patients require large surgeries, extended hepatectomies in order to get curative surgeries. And if your margins are positive, then the 5-year survival rate is only 5%. But if your margins are negative, then the 5-year survival is 40% rate. So getting that margin-free survival is really critical. So in a prospective study where Y90 was combined with gemcitabine and cisplatin, 22% of patients were downstage in a prospective phase 2 study. In another single-center retrospective study of 169 patients from Europe, basically 32 patients were downstage, and Y90 combined with surgery was associated with a survival benefit. And so these are, again, a number of studies which have shown successful downstaging. And I'd like to just highlight one of the studies from our center that was the latest one to be published, where we downstaged 42% of patients who were initially unresectable. 82% of those patients had an R0 resection margin. 63% of those patients who got resected had no living tumor cells when the tumor was cut out. And only 4 patients, or 36%, actually needed an extended hepatectomy. The surgeons were able to do a smaller resection because the radioembolization really shrunk that tumor, which is very promising data. So this is an example of that patient. So before treatment, very large tumor over here in the left lobe, very close to the hepatic veins, which Dr. Hernandez will tell you makes it a little bit challenging to get a clean margin. This is after the Y90, a month later. That lobe has really shrunk down. This was an 11-centimeter tumor. And here's the pathological response, where they found a necrotic tumor with no residual, even microscopically identified tumor. So if you do good dosimetry, if you give high doses of radiation, we can get tremendous effect. This is an example of another one of our patients. This is the patient's right lobe, which is typically the size of your head. So it's fitting underneath your rib cage. And when we gave this high dose Y90, and the tumor itself was 7 centimeters, it shrunk down over time to the size of the surgeon's palm and really could be cut out. So again, done well, we get some excellent results. So I think in terms of combination therapy, I do want to make everybody aware of this prospective phase 2 study that we're hoping will get to a phase 3 stage at some point, which combined gemcitabine, cisplatin, and Y90. Which gave excellent dosimetry, high-dose dosimetry, about 317 gray to the tumor. The disease control rate at 3 months was about 98%, but the exciting thing for us, and the way where we see Y90 or IR fitting in, is really getting those patients to surgical resection. And so 22% of the patients were downsized to surgery, about 20% of those had an R0 resection. Now, some others had shown this slide. The TOPAZ-1 trial was really encouraging for us. One of the things that we're doing at Beth Israel is that we have a phase 2 study going on, which is a single-arm study of Y90 combined with the TOPAZ-1 regimen, so gemcitabine, cisplatin, and durvalumab. And basically, we give 1 dose of the drug, we then do Y90, and then you continue on the drug. We've enrolled 3 patients so far, and we'll be going up to a maximum of 30 patients. So in summary, I think the older studies were mostly using transarterial and IR therapies in the salvage or second line. There was more use of chemoembolization. The newer studies are moving towards radioembolization in the first line. And then the combination trials are really coming to the fore. There's a lot of sites that are running those. We're thinking a lot more about downstaging patients and getting them to surgical resection, and thinking about Y90 in the neoadjuvant setting, although the trials for that are yet to happen. I am very excited to say that I've been speaking with the Cholangiocarcinoma Foundation. So there are interventional radiologists who focus on biopsies, ports, and biliary drains. And then there's interventional radiologists who focus on ablations and Y90s and during therapies. And so we're hoping that over time we can help patients who come to the Cholangiocarcinoma Foundation website also find interventional radiologists who are specializing in cholangiocarcinoma. Thank you very much.
Thank you for highlighting the very important role of liver-directed therapies in cholangiocarcinoma. Our final speaker is Dr. Jonathan Hernandez. He's a surgical oncologist and hepatobiliary surgeon, chief of the surgical oncology section at the NCI and NIH, and an associate professor of surgery at the Uniformed Services University of the Health Sciences. He specializes in the treatment of metastatic and primary tumors of the liver, bile ducts, and pancreas, as well as in the surgical management of complex abdominal tumors. Dr. Hernandez's research efforts focus on implementation of ex vivo human tumor systems that allow his lab to fully characterize tumors from the operating room and evaluate new therapies in an unfettered platform. The Hernandez lab utilizes these human tumor systems to develop combination therapies for recalcitrant tumors, delineate and target uncharacterized signaling axes for therapeutic gain in patients with cholangiocarcinoma, and elucidate the mechanisms through which tumor cells co-opt the microenvironment of distant organs to form life-threatening metastases. Thank you so much.
Thanks very much for the opportunity to speak today. I'm not going to talk about a lot of that. I was given the topic of clinical trials, and that's sort of a big topic, but what I thought I'd talk about would be something applicable to everybody in the room, and that is what the NIH is and what we can offer you, because everybody can come there. It's free, as you'll see. So the NIH is in Bethesda, Maryland. It is America's research hospital. Our task is really to do something different, and our task is translational science. It's mostly clinical trial related. It was opened in 1953. It's a 200-bed hospital. 1,600 clinical research protocols are active. Every patient has to be enrolled on a study. So we would not do necessarily standard of care type things. However, I will say that I will do this for you. I will do standard of care surgeries because we use the tumors in ways that were mentioned, but I'm not going to talk about today. It is totally free. These are your taxpayer dollars at work. We don't care if you have insurance. We don't have a billing office. Everything we do for you is totally free. So I think it's important that you know that anyone can come here. I review scans all the time for people, and I'm happy to do that. We don't have to have an official thing. I can sort of look at your scans, tell you what I think, and then guide you as best I can. There's a lot of notable, really cool things. You certainly heard Melinda's talk today, which is super cool. But first, at the NIH, cure of a solid tumor with chemotherapy, successful replacement of a mitral valve, description of the pathogenesis of AIDS. All these things happened in Bethesda, Maryland. So we're the National Cancer Institute is sort of broken up in two different ways. We have the intramural divisions and the extramural divisions, and I live in the intramural division, so I'm an intramural investigator. And so there's two parts of that, and that's the Center for Cancer Research and a different thing, but I'll talk about the Center for Cancer Research. It's 2,900 staff, 900 postdocs and clinical fellows, two major campuses. Most of the patient work is done, again, in Bethesda. If you look at what we do overall, it's mostly clinical and translational work, and it's mostly about cancer mechanisms. This slide is a bit old. It may have changed with the pandemic, but it's not really changed. So how do you get to see us? You can't just walk in the door. There's no emergency room. It's a hospital in a way, but we need to get records from you. We need to look at those records. We need to see if you're a candidate. Most of the time for me, that mostly means reviewing scans for people, and so you can get that to us in any number of ways. We screen for eligibility. We look, we evaluate you, and then I will guide you. If I don't have anything for you, I can certainly talk to Dr. Gretton or Dr. Rosenberg. We sort of work together, and so, I look at this as your taxpayer dollars at work, so this is all free. So when you look at the landscape for cholangiocarcinoma, and I stole this slide from Tim Gretton, things are changing, and when Topaz 1 came out, you can imagine the addition of immunotherapy. Things are going to get real busy real quick, and you saw a lot of trials, and for me to go through all of the ongoing trials right now would be, I think, overwhelming and probably not helpful to you. But what I'd like to do instead is go over trials that I have available for you that you may or may not qualify for, and I'll show you the results that I have, but I'm only going to go over my data. I'm not going to go over anyone else's data. Before I do that, I do want to say that if you have a resection done by me or any of my partners at the NCI, we will share your tumor with Dr. Rosenberg or anybody else. And so you may have a lot of things happen with your tumor that you may not realize. Some of the things you will know about, but some of the things you may not realize. And so if you're interested in TIL therapy, but you may be fit on a trial that I'm going to show you, we would definitely share your tumor with Dr. Rosenberg for that opportunity, if that's what you so chose. You'd have to meet with them. We'd have to plan accordingly, but these are possibilities. And so I told you before about Topaz, which I'm sure most people know. It added immunotherapy to standard cytotoxic chemotherapy. And so I had this idea a while ago, why don't we try an antibody-drug conjugate in addition to hepatic artery infusion pump therapy? And hepatic artery infusion pump therapy is really just regional chemotherapy. It's a way to put a special pump, looks like a hockey puck, sits on your abdominal wall. And this puts a certain drug, only one, as it stands right now, but we're working on that. Floxuridine, it puts it straight away into your liver. What's the advantage of that? Why would you do that? Well, we can give you 400 times to your liver what we could ever give you systemically. So we give you mega doses. And that strategy has been useful for patients with colorectal cancer, metastatic colorectal cancer mostly. But it could be better, in my opinion. And so one of the ways I thought to make it better was to combine it with this immunocytokine, which when you deliver massive doses of chemotherapy, you probably get a lot of cell necrosis. And why don't we deliver an antibody why don't we deliver a payload, IL-12, to that tumor, and we can change the immune microenvironment. And so that was the concept we had a number of years ago, which we've now started doing. And this is sort of what it looks like. And the trial has 2 arms, and I'll show you data from the metastatic colorectal arm. I've done 4 patients to date with cholangio, but I don't have enough data to show. I'll show you what I've done to them, but I don't have enough data about survival or response yet. But this is what this looks like. And so in concept is we would smash the tumor with the floxuridine through the hepatic artery infusion pump. We would deliver this immunocytokine after 2 weeks of delivery of that therapy, and that immunocytokine would deliver IL-12 into your tumor. And then you would change the immune microenvironment of that tumor. What does IL-12 do? It's a pro-inflammatory cytokine. It induces production of other cytokines like interferon gamma. It induces proliferation of cells that can kill the tumor cells, T cells, NK cells. It does those things listed there, activation of effector T cells. So here's what this trial would look like if you were to come on to study. So you would get an operation to place that hepatic artery infusion pump. And I like to play strategy. And so if you have a bunch of disease that I can cut out, and so I can leave only stuff that I really can't, I'm going to do that. And so you may have a good setup for a remnant liver that's going to be okay in the end. And so I like to do that sort of thing. It's not standard, but that's what I do. So at the time of that pump, you may or may not get an extensive liver resection, depending on where your tumors are. You get 2 weeks of floxuridine. That's 400 times the dose that we could ever give you systemically. That comes out of the pump. And then we give you this immunocytokine subcutaneously, which will deliver IL-12 into your tumor. That's cycle 1. Cycle 2 starts again, but we add in systemic therapy. And there's a bunch of really interesting immune analyses that I won't go into extensively. I started this hepatic artery infusion pump a while ago, and I can tell you my results, I wanted them to be better. They're in line with what everybody else got, but I thought we could do better. And so when I added in the IL-12, we were seeing better response rates. We obligated people to a biopsy after cycle 1, and a lot of that tumor became necrotic. We didn't really see that before. Now, this survival curve is too early for me to really show you this, but I thought I'd do it anyway, because I have a feeling this is going to be better. But you can see, and we haven't followed people out long enough, but I get the sense this is better than a hepatic artery infusion pump alone, so I'm super excited about it, and I think it's a good option for people. Okay. That I have. And then I've done this to a few patients with cholangiocarcinoma. First patient I'm going to show you is a guy, Mark, I'll use his first name. So Mark came to me from Lisa, and Mark had a really big tumor, and he'd gone through pemigatinib because he had an FGFR2 fusion. He went on to futibatinib, didn't do well on that drug, and he came to me, and he had multiple tumors, and he had portal hypertension, and that's usually an exclusion criteria for us. But I looked at Mark's tumor, and I thought, geez, that's a big tumor in the back. I don't even see your hepatic veins. Maybe this is causing an outflow type obstruction. Maybe you really don't have intrinsic liver disease. Maybe what you have is this tumor is just really your problem, and if we could treat that, maybe it'd be better. And so I put him on, and his ascites gotten better after a month, much better, which he had before. He had a lot of ascites before. This is me pushing the envelope. One thing you'll know about me is I will do that. Surgeons fall in the range of aggressiveness. I'm probably, here. And so, he had 20% viable disease at the end of this, and he's doing pretty well. And there were people who told me I shouldn't have done this for him, but I felt like he was going to do well. Here's a second patient I put on. Now, he had multiple tumors, and most of his left side was filled with disease. And so I thought, well, I'll remove the left side, shunt all the chemotherapy over to the right. I'll clean out his right disease. You'll see I filleted up his liver pretty good. But he's doing very well. He's got one or two tumors left. We're treating with that hepatic artery infusion pump. And so he got a combination of resection and ablation, which is usually what I will do for people. I'll use whatever I can to get down to minimal residual disease as best we can. Now, some of these were in places that you can't lose the blood vessels. I won't go into that in great detail, but that's why I didn't clean them out completely. The other thing we did for him was create organoids. Now, this is a good model to test drugs with. And so we sent his tumor over to another investigator, and they were able to grow the cells in these ways where they go in sort of clusters. And so it's not a cell line, but we think this better mimics in vivo biology. And so from him, we will have all kinds of tissue, and he will have options when we start to figure out what other drugs he may be sensitive to. And so we like to do multiple things like that for people. I like to think we're going to be able to offer multiple lines of therapy for people. I don't ever like saying we don't have anything to offer. The other thing he was a candidate for was something I'll tell you now. I'm going to switch gears a little bit. I'm going to tell you a little bit of a story. Now, this takes us back a bit of a ways now. I started working on this a number of years ago, looking for exosomes in bile, and because we were doing big operations for people, and sometimes they didn't have anything. There was no disease. And we couldn't always tell that, so we were looking for biomarkers, to be honest, and bile's sort of a nasty matrix to deal with, but we figured out how to isolate exosomes from it. Now, exosomes are these little things released by cells that carry protein in them. And I thought, okay, let's look at, maybe this is a prioritized window into the cell. Maybe we'll learn something. And so we did mass spectrometry, which is a way to look at all of the proteins in these exosomes. And what we identified was a protein I'd never heard of at the time called exportin 7. It's a nuclear export protein. Its job is to shuttle proteins in and out of the nucleus. And we said, okay, let's see the individual data. It looked like some of the patients with cancer had this, but not all. So I said, give me the rest of the bile from that bile bank we had. And we looked at it again, and it looked like, again, some of the patients with cancer, but if you didn't have cancer, you didn't have this marker. When we went and looked at it on the actual immunohistochemistry slides, it looked to be a cytoplasmic protein. But if you had in the normal biliary epithelium or in dysplastic tissue, it was a nuclear stain. Sort of interesting. It's being mislocalized. That's really interesting. So we said, okay, it's being stuck there. I bet it's bound to something important, and maybe that thing is targetable. Let's see. So what we did was we took some cell lines. We grew those organoids, same like I showed you from that patient, but this time from cell lines. We split the nucleus and cytoplasm, and we pulled down that protein, XPO7. And when we did, we sent it for mass spectrometry, and what we identified was a very strong relationship with a serine threonine kinase I knew nothing about called SLK. SLK, okay, that's interesting, maybe. So we needed to confirm that. We did the opposite sort of experiment. We pulled down with SLK, and we got XPO7, not surprisingly, along with some other interesting proteins that I won't go through. When you look at these computationally, they kind of fit. And so we thought, that's interesting. What happens if you kill SLK? You get rid of it. You genetically modify these cells such that you no longer have that protein. And then you inject these cells into the mouse liver. When you do that, what we saw is the tumors didn't grow very well, and when they did, they sort of looked very different. They looked like this cystic-y looking thing, not like the normal sort of tumors look. Then we said, okay, that's interesting. I wonder if the kinase function of this protein is important. And I am working up to a trial, so in case I'm boring anybody, it will get to a trial eventually. So we asked if the kinase function of SLK is important, because there are other examples of kinases that have other functions besides their kinase function. So we mutated the kinase such that it could no longer do its function. It could no longer phosphorylate, and that I'm not going to bore you with that. But the long and short of it is yes, the kinase function is important. And then we said, okay, well, we can't use short hairpins in people. We can use kinase inhibitors. These are a big class of drugs. Are there any that target this kinase? And as luck would have it, very characteristic of the NCI, we had this whole huge thing where we spent, I don't even know how much money, but we profiled all the known kinase inhibitors. And the reason we did that is because they're all dirty, and they hit multiple targets. And so there was one that is approved as a totally different type of kinase inhibitor for kidney cancer called tivozanib. It also hit SLK. And so we said, well, we need to prove that that's really true. And so we did X-ray crystallography, which is the best way you can look at two proteins interacting. And in fact, tivozanib does push out the DFG. It changes the configuration of SLK, meaning it actually bona fide does inhibit this kinase. So then we looked at it in patient-derived xenografts. Here's, I'm showing you two of them here. It definitely had some efficacy in the patient-derived xenografts. We said, well, what is this doing? Nobody really knew that. And so to go quickly, in the cell lines, it looked like it was inhibiting PI3 kinase activity. And then, PI3 kinase had been a pathway for patients with cholangio. It didn't work out for everybody, but there were some patients who did well. And so my contention is we're probably picking a population, but let me show you. And so then as said in the introduction, we have a way of keeping tumors viable outside of patients. And so we did this in a way for a patient with XPO7 positive and a patient with XPO7 negative cholangiocarcinoma. And lo and behold, that drug does work if you have XPO7 positive cholangiocarcinoma. It does not work if you have XPO7 negative. Most patients are XPO7 negative. We took some of this tumor, put it in our system, and treated it with a drug. Lo and behold, you inhibit PI3 kinase activity. Look at that phospho-S2 or phospho-AKT, threonine 308. You inhibit that activity with this drug, but only if you have that biomarker. So what I would say is this drug has been tried in multiple people across multiple tumors, but most of the time it doesn't work, but you would never give it to the people who it wouldn't work for. That would be stupid. You would only give it to the people it would work for, and that's exactly what we're doing in this study. Now, here are the patients I've screened. Now, this is just a couple of examples, but I'll tell you, it's about a third of people that can qualify. I've only treated 4 or 5 patients to date. Here's one. If you look at the scan on the left, you can see these. I'll draw your attention around the tumors, this white hyperemic area. We think this is the tumor invading into the local surrounding environment. And after 2 months on this study drug, this patient's CA19-9 went from unmeasurable, it's above 10,000, it's now 800, and you can see those hyperemic areas around these tumors are gone. This guy had been through every therapy you could possibly tolerate. So, this is a good option for patients. I got to know whether you're going to stay in positive, because I'm not going to treat anybody who's not. I don't think it's fair. Okay. Finally, in my 2 minutes, I will say we also have a trial open for patients with peritoneal disease. This is a difficult problem. It's thought that the chemotherapy doesn't get there very well. Once upon a time, we were looking for synergy with various drugs. I won't go into the whole story, but we found synergy between paclitaxel, which is a common agent used for chemotherapy in the abdomen, and something called nilotinib. Nilotinib is a blood cancer medication. Why these two work together, we don't really know that. But after a lot of effort and a lot of money spent, it looks like they do. And so we had this idea that we could combine the two, paclitaxel in the abdomen, oral nilotinib, and really augment responses. And so the concept is we put these catheters in the abdomen, and we give you these drugs for a period of time. If you look like a responder, then and only then would we consider something like a HIPEC, a cytoreduction in HIPEC. So this is the study schema. We've done this on a single patient with cholangiocarcinoma. We gave Dr. Rosenberg the tumor. I don't know the results of that yet, but we should know soon. Anyways, the goal is to try and downstage people and pick people for a HIPEC and cytoreduction who may actually benefit from it rather than just doing it to everybody. And so I think with that, my time is probably up. I didn't talk much about surgery, but I definitely can answer questions on that one. And if you have any questions about any of our studies, I'm happy to answer. That's probably all I got.
Thank you for sharing your very exciting research. And there are a number of investigators here from the NIH, including Dr. Hernandez, who I'm sure would be very excited to talk to you about trials available at the NIH, and Melinda can share her experience as well in more detail. Could we bring up the next set of slides, please? So now we're going to shift gears to a tumor board case series. We have a fantastic panel of multidisciplinary experts up here. And for those of you who aren't aware of what a tumor board is, this is a regular meeting of the minds where we bring together doctors and nurses and specialists from across all disciplines, everything from diagnostic radiology, interventional radiology, interventional GI, transplant hepatology, medical oncology, radiation oncology, surgical oncology, nursing, pathology. So it's a huge team of people. And our aim is to review patient cases in details, looking at everything from their history, labs, scans, and pathology to come up with the best treatment approach as a team. And this is not a one-size-fits-all approach. We really try and look very carefully at all the details of specific cases to personalize the treatment to an individual. So here is our tumor board panel. Again, Dr. Kodali is from transplant hepatology, Dr. El-Khoueiry is from medical oncology, Dr. Sarwar is from interventional radiology, and Dr. Hernandez perhaps can put on his surgical oncology hat for us. So we'll review a few cases, and I'm sure you all have lots of questions, and please pick the brains of these fantastic experts, in which we will definitely be happy to address in the Q&A. So the first case we'll talk about is a 65-year-old man who has a history of cirrhosis of the liver related to alcohol, as well as a very remote history of rectal cancer treated about 20 years ago. Patients that have cirrhosis of the liver undergo screening for another type of liver cancer called HCC, or hepatocellular carcinoma. And when he was undergoing this screening, they found a 4-centimeter liver mass that was a bit atypical for HCC, the type of tumor that they're being screened for. But luckily, there didn't appear to be any involvement of blood vessels or lymph nodes that looked larger. More commonly, when we see a tumor in the liver, it's much more likely that it's actually spread from somewhere else, that it would be metastasis from another site. So there's other workup that's really important to do for us to figure out exactly where this is coming from. So he also had upper and lower endoscopy to look very carefully at his GI tract to look for any tumors, which we did not find. He also had multiple scans, including a PET scan shown here, to look for any tumors outside of the liver, which was also negative. And eventually he had an IR-guided biopsy of this liver lesion that showed poorly differentiated adenocarcinoma. What does that mean? Poorly differentiated means just how abnormal the cells look under the microscope. And adenocarcinoma has to do with what type of cells this cancer originated from. And adenocarcinoma originates from gland cells. Poorly differentiated adenocarcinoma can be seen in many types of tumors. So our fantastic pathology colleagues are able to perform specific stains on these tumors to try and narrow down exactly where this cancer may be coming from. And in this case, they felt very strongly that this was either from the pancreas or the biliary tract. Given that there was no evidence of any pancreas tumors on these scans, we felt very confident that this was an intrahepatic cholangiocarcinoma that appears to be very early stage. His blood work and all of his tumor markers were very within normal limits. And so now perhaps with this information, I'm curious actually to go down the line and see what people think about how to approach this case in the upfront setting. And if you can turn on your microphones, that would be great. Dr. Hernandez, we'll start with you.
Sure. So this is a gentleman who we think, by all diagnostic measures, has localized disease. And so the questions in my mind really relate to whether this person can be a candidate for upfront resection. And so the key part of his history is the cirrhosis. Now, on the scan, I couldn't quite tell where that was. His spleen looked big. We would need other information about his liver to decide whether resection would be safe in him or not. What's his platelet count? Do we think he has portal hypertension? All of these things weigh into our decision. Certainly we can, technically, yes, easy to remove this, but we need to do this safely. And so patients with cirrhosis always we should take a step back, not rush, really gather up information. So I would involve the hepatologist at this point, and there's a number of data points we would need to sort of decide.
No, excellent points that were brought up that we also thought of as well. He does have a large spleen, as you can tell. Ideally, in these tumor board settings, we're able to scroll through all of the images. This is just a static image, so it's a little bit difficult to interpret. He does have a large spleen, but otherwise, his labs are normal, and no evidence of varices or other signs of portal hypertension.
Platelet count's okay, above 100, okay. So, I mean, as described, he would be a candidate for a resection.
Fantastic. Perhaps now we'll go to Dr. Sarwar, and what would you think about potential liver-directed therapies in this patient?
Yeah, so I think in this patient, I think the fact that it's poorly differentiated, and then also because the spleen is large, and there may be some question of liver failure after if a large resection is needed, although it looks like a right lobe. I wouldn't say that we would probably jump to a local regional therapy. One of the things that we would do at our institution is do a mebrofenin study, which is a nuclear medicine study that actually adds information on top of liver volumes to how the function of the liver is, of their future liver remnant. If the function was very good and if our surgeons felt comfortable, they would go for a resection. But otherwise, in somebody who has a poorly differentiated adenocarcinoma, these cancers are very aggressive cancers generally. And so the risk of spreading is also quite a lot. And so while we're waiting to work them up for the surgery, we can do Y90 up front. That would serve two effects. One would be to basically necrose the tumor entirely, and the second effect would be to shrink down the right lobe, make the left lobe larger, make the surgery a little bit easier. So certainly something to consider. I think I will say that this patient is really lucky to be not diagnosed without any extrahepatic disease, in which case, curative options would not be possible.
Absolutely. Dr. El-Khoueiry, what do you think about potentially integrating neoadjuvant systemic therapy?
Yeah, so as we said earlier, currently, if this patient undergoes resection, which I agree would be the standard, we would, after surgery, give chemotherapy to lower the risk of the cancer returning. And currently, the standard of care is a drug known as capecitabine, commercially as Xeloda. The improvement noted with that intervention is actually modest. So we need to do better in that space. And one of the ways that is being explored is to give the chemotherapy before surgery, because in multiple GI cancers, that approach seems to be better because more patients are able to get the therapy, it's better tolerated, and maybe leads to better outcomes for various reasons. So I think currently that continues to be, I would say, experimental, especially in somebody who's resectable up front, but definitely an area of investigation.
Great. And Dr. Kodali, transplant.
Yeah, so a couple of things. I think, the beauty of, having hepatology involved in somebody like this, with cirrhosis is when you see a liver lesion, of course, the first thing you think of is hepatocellular carcinoma. And, in the tumor board, when we review these patients, if it's not looking like the classic LIRADS-5, which is what there's a categorization that the radiologists use to differentiate between hepatocellular carcinoma versus others. If the index of suspicion is high, biopsy is perfect, and I'm so glad that if this is a real patient, they got a biopsy because it serves many purposes. It confirms the diagnosis. You know whether it's well differentiated or not, which helps you plan for how aggressive you need to be from a post-surgery, post-treatment monitoring perspective. It also gives you tissue that you can send out for next-generation sequencing, right? The molecular profiling, which is so important now, and I think every patient with intrahepatic cholangiocarcinoma needs that information sent out before treatment is started. Dr. Hernandez brought up really good points. I worry about portal hypertension. I worry about risk of bleeding, infection, and healing and other issues when patients with cirrhosis go for resection, even if they're gradient, which is what we measure when we check the pressure around the liver, the portal hypertension or the pressure gradient. If it's low and the platelets are good, yes, we would consider this patient for resection. Just given the poorly differentiated nature, I would get oncology consulted early on, and because we are a transplant center, I would also always have transplant in the back of my mind. So I would probably see if my oncologist on my multidisciplinary team feels if it's reasonable to start this patient on Gemcitabine Durva, especially given cirrhosis, assess in a couple of months, and then see resection versus transplant. And we also use Y90 for tumors that are larger than 3 centimeters, just for the reasons Dr. Sarwar mentioned, the contralateral lobe hypertrophy and other benefits that Y90 offers. And for some reason, if there's progression of the disease, then we know based on the data that we have in the last few years, Y90 offers long-term best outcomes from a local regional perspective also. So those are my comments.
Fantastic comments made by all. And you can see that this case really highlights how important having a multidisciplinary team is to coming up with the best treatment approach. And again, this is a patient that we absolutely, oh, go ahead.
Sorry,
please,
Haley.
please.
Can I make a comment?
Of course.
And medical oncologists tend to do this. You'll relate. I think what patients can be confused by, though, is there are slightly differing opinions, right? Or maybe complementary opinions. And sometimes patients ask, well, why can't I have that? It's because, one, there is different levels of evidence for the options that we are mentioning, right? And that's very important to highlight. Some things are proven, what we call level 1 evidence, a randomized prospective trial. Other things have lower levels of evidence, so the quality of the data is less definitive. There's also variability in practice by regions, by institutions, and those are all normal and accepted. But I just wanted to highlight that because it can be confusing.
Very important point to make. And I think that highlights another important point that the Cholangiocarcinoma Foundation is always making, is that having second, third, and multiple opinions is so important, because this is a little bit of an art in how we do this, and sometimes we have more or less evidence in other areas. But yes, we are definitely certainly trying to take this patient to a curative therapy. And I have a little wrinkle in this patient's case to see if that will change your management at all. So we did biomarker testing for this patient, as Dr. Kodali highlighted. And what we very impressively found was that this patient had mismatch repair deficiency or high microsatellite instability. When we see this change on a tumor sample, we actually send it for additional testing where we're trying to determine, is this a sporadic change or is this a change that was inherited? And in this patient's case, he had a germline or inherited mutation in a gene called MLH1, and that's consistent with the diagnosis of something called Lynch syndrome. And Lynch syndrome is an inherited cancer syndrome. Patients with this condition are at higher risk of endometrial cancer, ovarian cancer, as well as pancreas and biliary cancer. And in sort of normal situations, our cells have the ability to repair any errors in the DNA, in the genetic code, and fix them. But in patients that have Lynch syndrome or mismatch repair deficiency, the cells are missing the instructions to be able to fix these errors in the DNA. So you get accumulation of multiple different mutations, and that's what's sort of propagating cancer. And what's so important about doing this biomarker testing and finding these rare patients that have mismatch repair deficiency, we see it in about 5% of cholangiocarcinoma, is that these tumors are super sensitive to immunotherapy. So with this information, I'm curious, does this change anyone's thoughts on upfront therapy?
I would say it would change mine. Okay, so when I think about, you heard a little bit about should we give the therapy up front, we do it in other diseases. I promise you 100% of that tumor is going to die when we cut it out. And so let's say you try and shrink it a little bit. What is that going to do? Really what we're trying to do is hit the cells we cannot see. And so we don't really have very good data to say any of these drugs really do that, except this one. And the operation may change substantially because the patient may not need one. I have seen a number of these MSI-high biliary tract cancers just go away. Mm-hmm. And so I would say, is the operation going to change? Yeah, it may not be required. And so, and if that's true, in my mind, neoadjuvant therapy, if it's going to change the operation, it makes some inherent sense. You wouldn't put someone through something for no reason, and we don't really have data to suggest that. But in this scenario, I would say, I think this patient ought to be considered for this therapy up front. I would hold on surgery. It should also be said that, if you look at the SEER database, right hepatectomy, mortality, 90-day mortality, although, people who do a lot of this don't think too much of it, but if you look at the national databases, 5 to 10% 90-day mortality with a right hepatectomy, that's bone crunching in somebody who may not even need anything done.
great points. Anything else? Yeah.
I mean, fully agree, because even in these patients, just to clarify or add to what Dr. Hernandez said, even if you still see a tumor in place, if you take it out, it may be all dead. So we're seeing this quite commonly with MSI high tumors, so fully agree with immunotherapy up front to see what happens.
Couldn't agree more. And again, as has been highlighted in these patients with mismatch repair deficiency or microsatellite instability, we've seen complete responses in many of these patients. This is certainly a little bit of a data-free zone in cholangiocarcinoma specifically, but extrapolating from other tumors where this is a bit more routine, this is absolutely our approach for this patient, is to do upfront neoadjuvant therapy, and potentially this patient won't even require surgery, which is very exciting. And that's why biomarker testing is so important, to find these sort of needles in a haystack with a rare cancer with a rare presentation being caught so early, and then an even rarer biomarker, but that will have an option for really fantastic therapy. So our next case is a 34-year-old gentleman, very healthy, no prior conditions, had presented to his primary care doctor with elevated liver labs. He had multiple scans that were showing concern for strictures in the bile ducts, as well as for a condition called primary sclerosing cholangitis, PSC. There's at least one patient with that here at the conference. And he had an ERCP and an endoscopic ultrasound at another hospital that showed multiple biliary strictures. As is very frustratingly the case with a lot of these types of tumors, when we do brushings of the bile ducts, they often are negative for cancer and only show sort of atypical or reactive cells. And patients can often require several procedures to really confirm a diagnosis that we feel very highly suspicious of. But he did have a large lymph node in the area that was positive for adenocarcinoma, so confirmed the cancer diagnosis. During all of this workup, he had a PET scan shown here that showed that there was really intense uptake in the liver, which you can see surrounded by the green circle, as well as multiple lymph nodes, including one that's pretty distant and far away. His liver lab shown here did improve significantly after having stents placed, and his CA19-9 tumor marker was elevated at baseline. So again, putting all of this together, it does seem like this gentleman probably has advanced extrahepatic cholangiocarcinoma. And we did biomarker testing, which did not show any currently targetable alterations. So maybe I'll pause here and see what people think. And maybe, Dr. Kodali, we could start with you, and if you could just review the transplant eligibility criteria for extrahepatic cholangio.
Absolutely. So yesterday during the dinner, I think one or two patients mentioned primary sclerosing cholangitis. It's your immune system related disease. It's not very common, but it's one of the common reasons to develop cirrhosis, and also a big risk factor for cholangiocarcinoma. Of course, abnormal labs prompts visit to your primary care physician, who may do more testing and may refer you to see a liver specialist who may be able to diagnose a patient with primary sclerosing cholangitis. So there's a large number of patients that we as hepatologists follow along, and as they're being followed, if there is development of cholangiocarcinoma, it gets diagnosed sooner versus somebody who's completely asymptomatic and has never had any symptoms and presents with abnormal labs. So that's usually how PSC patients may present, either during routine follow-up or as a new incidental diagnosis. From a transplant perspective, for patients who have what we call as hilar cholangiocarcinoma, which is the cancer arising at the bifurcation of ducts, that is known to be an indication for liver transplant. We call them clad skin tumors. And those patients, the Mayo Clinic had started transplanting these patients, and most centers in the country here now transplant patients with hilar cholangiocarcinoma. There are 3 diagnostic criteria, and patients have to meet 2 out of 3 criteria. One is a malignant appearing stricture or an abnormal stricture, which measures less than 3 centimeters in size, positive brushings or biopsy, or a CA19-9, the biomarker, which is more than 100. So if a patient has 2 out of 3 criteria, that by itself is enough for that patient to get evaluated, listed, and they actually get eligibility or exception points or priority because of having that diagnosis, and they move up on the list and get transplanted. That's for patients who have cholangiocarcinoma. Sometimes if the cancer extends down the bile ducts, then our surgeons are able to do a transplant with what is called a Whipple, where head of the pancreas is also removed, and that surgery works out for most part. For this patient, and probably Dr. Hernandez will comment about that, having nodes outside the liver or extrahepatic disease is a contraindication for transplant. So transplant is unfortunately not going to be an option, but irrespective of what treatment the patients get, because it's a chronic liver disease, hepatology, as we stay involved in managing these patients, because like somebody mentioned yesterday, ascending cholangitis, which is infection of the bile ducts, is extremely common in this disease condition, and hence a multidisciplinary approach is extremely important.
Dr. Hernandez, maybe you could comment next.
Yeah, unfortunately, I don't see transplant or resection in any way as an option for this person. The criteria for hepatic artery infusion pump with PSC, the toxicity from the pump is biliary, and if somebody has a background of primary sclerosing cholangitis, I personally would not do it. I don't know of anyone who has, but that would worry me. This person has a difficult sort of problem, and I think probably with systemic therapy up front or probably would be the way to go, given the disease in the liver and outside. The stents are problematic. It's tough.
Yeah. Dr. El-Khoueiry.
I fully agree. So it would be systemic therapy up front. Question is it safe to use immunotherapy here or not, with PSC having immune etiology? And I don't think we have a definitive answer in that regard, but honestly, overall, the benefit of adding the immunotherapy to chemo is modest. We believe that it's mostly beneficial in intrahepatic cholangiocarcinoma, even though the current subgroup analysis suggests all patients benefit, but it's more benefit in intrahepatic. And I worry about the trajectory of patients like this because the PSC can certainly worsen, liver function can worsen. So I probably would avoid immunotherapy up front and just give the chemo alone.
Fantastic.
Yes, so we usually, I guess, again, multidisciplinary on oncology decides, but for autoimmune hepatitis associated cholangiocarcinoma and PSC associated, we technically just stick with GemCis if possible.
I'll just add that I think, I didn't notice the patient's bilirubin, but if the bilirubin's elevated, then before we do systemic therapy, you either get endoscopically placed stents, which I think most of the transplant centers prefer. If you're a candidate, if you have this kind of issue and somebody's considering percutaneous biliary stents, one of the things to be aware of is that some transplant centers will exclude you from their protocol if you've had a percutaneous drain placed, because they're worried that percutaneous access will cause some kind of seeding. So just something to keep in mind if you hear about a patient who has that issue. The other thing I'll say is that PSC, even when there's no cholangiocarcinoma, can present with multiple biliary strictures. And sometimes, even if the cancer goes away or the cancer is well treated, the quality of life with having these multiple drains is really poor. And so sometimes that becomes a bigger problem than the cancer, which may or may not progress very rapidly.
Completely agree. Thank you for all those points. So I should be honest that I wasn't involved in the decision-making point at this point, but I completely echo the concerns about giving immunotherapy in a patient like this. I do know there were extensive multidisciplinary discussions had about the pros and cons of adding immunotherapy. Given that he's a 34-year-old man, the decision was to give it a go. So he got first-line gemcitabine cisplatin with durvalumab, recognizing the risk factors of the immunotherapy with his concurrent PSC. Very luckily, he had, after 6 months of treatment, a really incredible response with decreased size of that liver lesion that we saw, the lymph nodes, and when he had a PET scan, nothing lit up. So now I'm curious, in this setting, after 6 months of systemic therapy with a really fantastic response, what would people do in terms of next steps? Would you continue systemic therapy? Would you do some sort of consolidative approach?
That's a pretty good response. I usually say if it's working, you should not stop. He's young, he can probably tolerate this. I'm a little surprised you didn't have any trouble with the durva, but that's cool to know. I probably would keep going, and then if he got to a period of time where, you really didn't see anything, I think for somebody like this, you'd ask a transplanter, would you consider this? Knowing this guy had an excellent response, what would be your time window you'd want to see? No disease or maybe liver only? You certainly don't know there's nothing left. But by your metrics, you don't see it, which is encouraging, but I would probably continue.
I mean, I agree, and I would maybe just go to a maintenance approach, so at least remove the cisplatin or potentially both the chemo agents and keep the durva, but either way, just because the chemo eventually takes its toll, so, but transplant.
So, if typically extrahepatic disease, no transplant. We've had discussions within our institution for patients with intrahepatic cholangio, where if there's a positive node in the hilum, after like an year of everything being stable and PET negative, should we consider those patients? But typically, the risk of recurrence is extremely high, so that's why transplant would not be an option at most centers in a patient who has documented positive nodal disease.
Can I ask you, so let's say 2 years go by, and he has that spot right there that's circled, and that comes back, and that's all he has. You would still not consider him, even though that window of time has passed, and he's sort of proven that he's at least not going to fail quickly outside?
So again, I think personally, a young patient like this, I would consider, but of course, it comes back to the multidisciplinary tumor board. You got to go through UNOS to get accept all of that. So I think there is going to be a concern for high risk of recurrence. The other thing, if there were no node positivity, which is not, I guess, a different scenario, then I think the concern about immunotherapy also lies in the fact that we worry about post-transplant acute cellular rejection. So that's the concern, but that's a completely different topic. But that's why this whole fear of, the patient is on durva, when do you stop it? Especially if you're talking about anti-rejection medication post-transplant.
Great discussion. And one last point I just wanted to make is that, if you can see that his initial biomarker testing that he had, several years prior didn't show anything that was currently actionable at this time, and he's had such a nice response to his current therapy that we would certainly continue as long as he was continuing to respond so well and tolerate therapy. His biomarker testing on sort of more modern review does show that he has indeed a KRAS G12D mutation. Dr. El-Khoueiry spoke briefly about KRAS mutations, which, just to briefly review again, was thought to be this completely undruggable target. But now, in very recent years, we have approved therapies for patients with G12C and a number of clinical trials available for these specific mutations. Dr. El-Khoueiry, any thoughts on the KRAS mutation?
I mean, it definitely opens up potential clinical trial opportunities in this situation. Whether this enhanced his opportunities for response to the immunotherapy or not remains to be a question, but that's just hypothetical. So I think it does open up clinical trial options down the road. Unfortunately, most of the drugs commercially available for other cancers are target G12C. This is a G12D, so it'd be clinical trials at this point.
Yes, perfect. But yes, a lot of exciting clinical trials happening for all KRAS mutations, including G12D, and even some drugs that are targeting multiple different KRAS mutations. So a very exciting space. So we'll move on to our last case. 50-year-old woman, again, very healthy, no prior medical conditions, had presented to an urgent care with a pathologic fracture of her spine. She had scans that revealed really widespread metastases involving the gallbladder, which is lit up very brightly here on the PET scan, as well as the lungs, lymph nodes, and spine. She had a decompression infusion of the spinal fracture, and they sent off that tumor to pathology, which confirmed that it was metastatic adenocarcinoma that most likely came from the pancreas or the biliary tract. And again, looking at the whole picture together with the pathology and the scans with this really brightly lit gallbladder, we felt very confident this was metastatic gallbladder cancer. Very healthy person, so completely normal labs, had an elevated CA 19/9 to 1200 at baseline. And again, the importance of biomarker testing, She came back and had a very strongly HER2 positive tumor. HER2 is another one of these important biomarkers that we have multiple therapies available for. By immunohistochemistry, it was 3+, which is our highest staining. And even by next generation sequencing, the copy number or the number of these HER2s on the surface of the cell that are telling this cancer to grow was more than 20 copies, which is very high. So maybe Dr. El-Khoueiry, I'll start with you and what you think about systemic therapy options for this patient.
I mean, certainly systemic therapy is the way to go. The HER2 positivity definitely expands the therapy options here. We don't know that we should alter first-line treatment today based on the HER2 positivity. However, we know that certainly after progression on first line, targeting HER2 becomes definitely appealing with very promising data from multiple different agents. More and more coming on board. So I think it does expand the treatment opportunities. Also, I should mention that there are now at least 2 trials that I'm aware of launching, looking at targeting HER2 in first line, meaning chemotherapy, immunotherapy, plus a HER2 targeted therapy in first line.
Fantastic. So I will say that we took a bit of a gamble with this patient because she was so healthy. She had this very strong HER2 positivity, extrapolating from some of the data that Dr. El-Khoueiry mentioned. In other cancers, even including stomach and esophagus cancer that's HER2 positive, we're using these HER2 therapies in the frontline setting. And actually, Dr. Oswald, who's here at our conference, was the lead author of a study looking at combining chemotherapy with HER2-directed therapy in the upfront setting. So we were able to convince her insurance company to let us give our standard of care gemcitabine cisplatin immunotherapy and a HER2 antibody, trastuzumab, in the frontline setting, and had a really phenomenal response, both in terms of her CA19-9 tumor marker decreasing really to normal levels, as well as on scans, the tumors essentially just melted away, which is very exciting. After about 9 months, she did have a little tick in the CA19-9, and that prompted us to get scans, which showed really no evidence of cancer anywhere else, but did show this really small spot in the liver. So with such a nice response to this combination of our standard treatment and the HER2 treatment, I would be particularly curious to hear what Dr. El-Khoueiry and Dr. Sarwar think about approaches to this.
I think he should speak first.
Yes.
Which already tells you my opinion.
So I think this is interesting. I think this is one of the areas where there's 2 ways to approach this. So one way to approach it is that you could say that you could move to a second-line systemic therapy. And there's a school of thought that says that a PET scan shows you active disease that is visible as far as the the capability of a PET scanner is concerned, but there might be microscopic disease everywhere else that the PET scan's not picking up right now. And so that school of thought would say, change the systemic therapy, go to a second round of systemic therapy. There's a second school of thought which says, well, there's this single focal lesion. Instead of hitting it with a really big gun, if you have very effective local approaches, so first of all, if the patient's a candidate for resection, it looks in terms of location, then they're not. Consider resection. That's a really big gun, has some morbidity, some time to recovery. Ablation is something I talked about where if this is less than 3 centimeters, you could ablate it, or you could do radioembolization and really kill these tumor cells. The third way to think about it is that you could accept that there is microscopic disease everywhere. However, patients also go through a lot when they're getting systemic therapy, and some patients don't have the capacity at a certain time to continue with multiple lines of chemotherapy because the second line and the third line typically will go lower in efficacy and higher in side effect ratio. And so in that case, there's this concept of doing a chemo holiday. So you take a holiday from the chemotherapy, we treat it, we watch it for 3 or 6 months, knowing that it's going to come back, knowing that it's a Band-Aid approach, but it might be the best approach from a quality of care standpoint.
Fully agree. So one thing I would add to bring up the concept of tumor heterogeneity. You know, it's weird that all these other lesions disappeared and this thing popped up. So is it a different clone of the tumor? Does it have a different mutation profile? So this is a place where I would definitely try and get more information about this, either through a biopsy or at least a liquid biopsy, to look if they have a different mutational profile in this lesion, why it kind of popped up at the site of resistance.
Yeah, I would agree with that. If I were managing this patient, I would call you and say biopsy that and ablate it. Now, you know disease is going to come back, but you can hold your second-line therapies back until it does. I think the patient does best if we've gone into a whack-a-mole type scenario here where you kill whatever raises their head, and if this is all you got for now, you hold back the systemic therapy. You take a biopsy, you ablate it, you get rid of that, we get more information. And then we keep going. That patient goes as long as they can. We don't have to use our next set of drugs until something else comes up. And if that is ablatable, I personally would continue to do that as long as that was an easy option. Now, certain times, depending on where you place that tumor, you know, it may not be so easy. I can't really tell without seeing the portal venous phase on this if this is near the left inflow. But I think, you know, that's how I would be thinking about this.
Fantastic. So that's exactly what we did. So we got a biopsy of this one liver spot that had popped up to try and assess for any resistance mechanisms. Unfortunately, nothing popped up. It was still very strongly HER2 positive. But again, I think we're still learning a lot about HER2 resistance. And we did ablate this, and the plan is to be able to, you know, continue watching her for a long time. And she, you know, got ablative therapy, and then, you know, oftentimes the tumor marker may rise just a little bit after that procedure, but then it's come nicely down, and she's, for all intents and purposes, NED at the moment, which is really fantastic, and then has lots of other systemic options as a backup if needed in the future. So that is it. Thank you so much, everyone, for being here. I really couldn't say it better than the Cholangiocarcinoma Foundation, which that there is strength in community and hope in research, and we hope you all feel that being here. And we're now happy to take questions.
So just as a reminder, if you can keep your questions general and not personal, that will be helpful. They will not be able to answer your personal questions, so keep them general. I have multiple virtual questions, so I'll just put those in between the patient questions. They're here.
Hi. I just wanted to tell people my experience at the NIH, the National Cancer Institute. I get treated at the Rogel Cancer Center at the University of Michigan. I had enormous trust in them, but I know I needed a second opinion, and it was so easy, guys. They even pay for you to ship your slides, your records, and all that. It was so simple, and I did a video appointment with Dr. Greeton, who agreed with everything. It was fabulous, and I can't recommend it enough.
Real quick, will you touch on international patients coming to NIH? Because we have Canadians
Yes.
and international patients here.
Yes, I just want to say I did not give you any money to say what you just said. So international patients, you'd think you'd have to be an American taxpayer. You do not. We certainly accept international patients. I operate on international patients. The travel pay, so we pay for you to come to the institution. We pay for you to stay. We will not pay for you to travel internationally. So you have to get to the U.S., but once you get to the U.S., we will then sort of take over. And so it's still the same with the caveat that you got to get to the U.S., but there is no exclusion for international patients.
Yes, thank you for all your presentation. That was really good. Mine is a more general question for all of you, whoever can answer this. With all the advancement that we're doing with the treatment of the cholangiocarcinoma, and all the clinical trials that are going on, how would you address the quality of life, the absence or the presence of it? More likely the absence of the quality of life. Is it worth it to extend a person's life for a year or so, but in the end, suffer through the side effects?
So I'll start, since I guess I'm one of the medical oncologists here, see what Dr. Ellis wants to add. Look, you touch on a very important point of cancer care, right? And there are personal choices that have to be made, right? So we discuss with patients their goals of care, what are their priorities, and what is their preference for their journey. Most patients still opt for any life prolongation that's possible at a reasonable cost to their quality of life. Now, the way we try to address quality of life is becoming more and more common and more embedded in the way we treat cancer, which is great news. For example, you heard me talk about maintenance therapy, meaning lightening up the chemo component to maybe reduce the side effects when the patient's doing well. That's one tactic that we have incorporated. Some of the targeted therapies, even though they still have side effects, may not be as toxic in all patients as much as chemo. So some of the therapies have maybe a better profile now. There's also more and more supportive care studies, looking at ways to enhance appetite, etc. Now, the challenge with cholangiocarcinoma is something that was alluded to earlier, is it's more than one disease, especially if you have bile duct obstructions, repeated infections, bad liver function. So there is an impact outside the cancer that's also affecting quality of life. And we try our best to palliate those issues as well. But it's a very challenging area for sure.
I completely echo what Dr. El-Khoueiry says. And the one thing that I would add, which he sort of touched on a bit with sort of the increasing role of supportive care, is the role of palliative care in patients who are still getting active cancer treatment. These are specialists who focus on symptoms including pain, nausea. They can help with sort of figuring out goals and what your wishes are to align with that. And they're a very integral part of our multidisciplinary team for many patients.
Okay, so my question, I'm going to try to make it as general as I can. This is for Dr. Hernandez, and I have actually two, another one's a general. The first one is, if you had seen somebody with peritoneal mets without any, the liver cancer was removed, and then post-operatively 8 months later, we had this mets to the peritoneum. Is the HIPEC procedure a procedure that you would consider for that type of person?
I would say the results for HIPEC with cholangiocarcinoma have been disappointing, very disappointing. You know, even when you pick a disease that metastasizes to the peritoneum as a primary sort of means, like you take ovarian cancer, it has benefit in that scenario. But outside of that, we've been disappointed with the results. So I think a selection filter has to be applied. Otherwise, there's a fair amount of morbidity to that. And so this is why we came up with okay, we'll take you to the OR, we'll put catheters in, we'll put chemotherapy into your abdomen that way. There's less morbidity that way. And if it looks like you're somebody who may respond and time goes by and you only have peritoneal disease, then I think we talk about it, we consider it. But I think just doing this because a patient has peritoneal disease, it's rough. Okay. And I'm not convinced we're helping.
Okay.
I hope that answers your question.
Yeah. And then the last one is this is a general question for anyone. Somebody with a cholangiocarcinoma with mets to the L4 spine. I mean, what would you consider management for that?
So I might jump in on that one. Again, I think the spine is another area similar to the last case that Haley showed, where if you have an isolated metastases, I think there's several questions to answer. One is that the only site of disease, obviously? Secondly, is it in a location that it can be safely be treated? Because if it's too close to the spinal cord or spinal canal or the nerves, there may be questions. And then third, even if you have multiple sites of disease, if this disease in the spine is causing severe pain, or is causing or may be at risk of impending collapse, then there are two ways to approach it. One way is through external beam radiation therapy, or SBRT, and that primarily provides a benefit in terms of tumor control in what we call the oligometastatic setting, meaning that you only have one or two tumors that are outside of the primary area and that are growing. The other way to approach it is that there are interventional radiology techniques in which we combine ablation with the use of cement and other things that kind of buttress the spine and prevent it from collapsing, which help not only with the pain, but also the tumor control. So when I think about a metastasis in the spine, my two questions are, is this causing pain or not? And then two, is this going to cause a structural issue down the line that would be beneficial to treat this in a local fashion?
First, I'd like to thank all of you for being here and presenting us with this mind-boggling alphabet soup of medical terms. And the question I have is a little bit off to the side, probably more interventional radiology than anything else. And that is it's relating to stents and drains. And has there been any research? Are there any other options other than stents for a repeated cases of ascending cholangitis? Is there anything happening other than putting in stents and taking them out and putting them back in?
So I'll say that the short answer is no, there's no research that I'm aware of. There has been research in terms of that I've performed myself in terms of percutaneous biliary drains that show that larger drains are better than smaller ones. I'll say that I've been out in practice about 10 years, but even in the last 10 years and while I was in training, most interventional radiologists wanted to put the smallest drain possible. Because they thought that larger drains would cause more damage, and it actually turns out that smaller drains, for example, tend to occlude more frequently, and so they bring the patient back more frequently. The other thing I'll say is that some of our most complex patients with biliary disease who are coming back repeatedly, again, not all of them, but a good 60% of them usually have an anatomical issue that's not being addressed. So for example, somebody had mentioned in the beginning, somebody who has two drains may actually need a third drain in order to fully drain the system. There's about 40% of patients in general, and then in our practice in particular, maybe like we have 5 or 6 people a year in whom we don't have a good solution for their drains. But most of patients, I think if you just spent, it requires time and effort and really thoughtfulness. So usually we can get to a solution that they can be either drain-free or drain-free for a prolonged period of time. But like minority of patients stay on that 3-month schedule and they can't get drain-free. But it's again, in general, I'll say that's my answer. In specific, every patient is different, and looking at the scans and really making that determination is important, kind of how to go about it. I don't know if Dr. Kodali has a perspective from ERCP standpoint or other things.
Thank you. So it is very challenging. I think in addition to having to go every so often to get the drains exchanged, when we see patients in the clinic, there's pain, there's redness, there's sometimes the drains are not working properly. So what we've done is, of course, we work with interventional radiology a lot, but we also work with our advanced gastroenterology colleagues, and sometimes patients need internal drains, which is ERCP-assisted drains, in addition to our IR folks doing the external drains. One thing that has worked really well for our patients is, one, if possible, having home health or someone go check on patients and check on the drain, output, the site, etc. But we also try to get an appointment with the PA, with the IR department, because in addition to their regular appointments, just going in and getting a quick drain check either in the surgery clinic or in the IR clinic has worked really well for our patients. And the third thing I talk about when I see patients is, in spite of everything working well, given the whatever the etiology or the reason for the liver disease is, infections, in spite of things adequately draining, are still possible. So sometimes in patients who've had episodes of infection more than twice, ascending cholangitis, we also send out a prescription for antibiotic and tell patients to start taking it if they start having fever or chills or right abdominal pain before they come to the ER, because early antibiotic use sometimes prevents these episodes of sepsis, etc. But it's a very difficult, challenging, and frustrating problem for the patients, but also the providers. And sometimes you're calling 4 different people trying to figure out what else can be done to help with the situation.
Yeah. Or do we still have time? Okay. We got 3 more questions, I think.
Thank you. Curious for patients with TSC1, if you have any thoughts on the use of everolimus along with the frontline treatment with the other gemcists?
So I would say in biliary cancer, we don't have any data for combining everolimus, which is an mTOR inhibitor that sometimes works in other cancers, but that's changed. We don't have any data in biliary cancer per se. Certainly, I think it would be something that could potentially be evaluated in a trial setting. So that's what would be my recommendation.
There's actually a trial currently for multiple solid tumors for patients with TSC1 and TSC2 mutations, so I'm happy to talk to you afterwards.
This is for Dr. Hernandez. The XB07 that you talked about, is that found on a normal biomarker test, or how do we find that?
No, it's not done on a normal biomarker test. You have to send me your slides and we'll do it.
Okay.
Yeah.
Perfect. Thank you.
No problem. We'll pay for the shipping.
Just to add to that, Dr. Hernandez, we have a lot of questions online asking how they send you their information. Could you just share that again?
The easiest thing and quickest thing for me to say is if you send me an email, my email's published, it's my name, jonathan.hernandez@nih.gov. If you send me an email, you'll have to tell us where the slides are. We'll have to sign some forms, and then we'll get a hold of your slides. But the easiest thing to do, if you send me an email, I will forward it to the right people and put you in contact with a research nurse and our nurse practitioner and get it done.
Okay, and you can also send an email to info@cholangiocarcinoma.org, and we will send you Dr. Hernandez information.
Okay, good.
Hi, I just had a question about the NIH study regarding the peritoneal carcinomatosis. Do you have to have failed first line to participate?
Yeah, that's a good question. So almost every study at the NIH is a second line study. We really don't do a lot of first line stuff. And so, yes, you would have to fail at least first line for that study. Okay.
And if you were to participate, what's the commitment time-wise?
Yeah, that's a good. So for you're specifically the peritoneal study. Mm-hmm. So you have to be back, every 3 weeks. So these studies are, I think one of the questions was about quality of life. What I always talk to people about is the time commitment. And what you realize when you talk to people is, as much as I hate to admit this really becomes what you do for a period of time. I mean, it just really does. I mean, it's what you do. And so for the hepatic artery infusion pump study, I got to see you back every 2 weeks. And I obligate you to get the chemotherapy for reasons I'm not going to go into at the NIH, which means you're in Bethesda for 3 days. 3 days every 2 weeks is not insignificant. And this really becomes, so I think the time burden is really something we really need to make everybody aware of. And so we got to see every 3 weeks on that catheter study.
Okay, thank you.
Last question. Yeah.
I'm just wondering, with Y90, when it was offered to me, I didn't remember hearing any risks or long-term risks. I'm wondering if there are actually any long-term risks to getting Y90, and if you could go over maybe the top 2 or whatever risks that there may be for somebody looking into it, if there are any.
Yeah, I think, there are 3 risks to be aware of. Bleeding from the site, which is usually the arm or the leg, and that's bleeding extremely rarely life-threatening. It can be stopped by just putting your finger on it. Infection is a risk, especially in patients with biliary catheters, but that's really well managed with antibiotics, doesn't become a long-term problem. The one to be aware of is non-target embolization. What that means is that if the beads end up in a place where you don't want it to be, the common sites would be the lung, the bowel, or the gallbladder. And so for those 3 sites, that's why we do the planning procedure. Most hospitals which are doing a lot of this, in the planning procedure, they'll pick up that problem and they'll block those blood vessels off so that none of the radiation goes there. In terms of the radiation itself, the reason why most places will not have large complications from this procedure is because our ability to give the radiation in a very focused manner to 1/8 or 1/10 of your liver is really good, because we can just select a vessel and just blast it with a lot of radiation. And so for all of those reasons, generally it's quite a safe procedure. In patients who've been on multiple lines of systemic therapy, then when you're even treating a small amount of liver, sometimes we say those patients, even though their liver function is normal, they're sitting on a knife's edge, and just that high dose of radiation tips them over into liver failure, and they start developing ascites or other things. So that could be considered not precisely a complication, but I would say a side effect or a risk.
And very quick yes, no. If you've actually had Y90, you've got resection, but the cancer's back, is Y90 even an option at that point, or is it, well, you've had it once, you've...
Depending on how the radiation was given, as long as the radiation was given in a what's called a segmental fashion, yes, it can be given. So I think for external beam radiation, there's a lot of caveats as to whether it can be repeated or not. Generally, in expert centers for internal radiation, those caveats don't apply, again, because we can give it in a very focused manner so that it only affects the tumor and doesn't affect the normal liver. That's a general response. Just have to proceed cautiously.
Absolutely. Okay, great, thank you.
Okay, I promise. Last question, and then we're going to break.
All right. So, you know, we've gotten such a lot of great information about the Y90, but where do you see the place for, you know, as you call it, external beam, the more traditional radiation, proton radiation? Where is that? What's the place of that in treatment options?
So I'll say a few words, and then I'll invite my colleagues to jump in as well, because I think MGH does a lot more proton than we do at Beth Israel, so I don't have experience with proton. I think this is an area where it's challenging. I think all of us on this panel and like physicians who are involved in this would love to be able to do the trials that definitively prove whether one therapy is better than the others, but the reality is that's never going to actually happen. I think that I will say that for extrahepatic cholangiocarcinoma, external beam radiation therapy is very good. I also think that, unfortunately, again, one of the reasons why I would love to have IRs be or patients with cholangiocarcinoma be more aware of what interventional radiology can offer is that it also depends on the center where you go to. So you can go to a center in Boston and the radiation oncologist is terrific, and he can do a really great job with SBRT. And you could go to another center in Boston where the interventional radiologist is terrific, and he can do a much, like as good a job or a great job with Y90. And so I think that's why a lot of the centers, the studies that I had shown, the centers who are getting good results are publishing their results, putting them through peer review. So if you have the opportunity to do that, that's one way to find centers, because centers that generally are publishing their results are kind of proud of their results and saying, hey, like this is what we can do. And then that's a good conversation to have. And so if somebody's published on proton, then you could probably go talk about that. But I wonder, it's a difficult problem. I don't have a good answer to this.
It is a difficult problem, and I think that's why the multidisciplinary discussion is important, because all these are options. None of them are proven to be superior to the others, unfortunately, so you have to use what's appropriate for the individual patient and based on the local expertise as well.
I agree. I think local expertise does matter because, you know, I mean, I can speak for the medical center in Houston. You know, we may recommend Y90 and, you know, the center across the street may say, this is actually a very good case for external radiation. You know, oftentimes in tumor boards, when we discuss patients and want to come up with a plan, one thing that's always brought up, and I'm not a radiation oncologist, is, yes, this tumor could be treated, but, you know, we worry about it being so close to the stomach or, you know, bowel. So I think all of those things are taken into consideration. And, you know, as has been mentioned, I think it just depends on the center and how comfortable they are doing one versus the other. So you'll get two different answers if you go to two different centers sometimes for the same problem. Doesn't mean one is better than the other, it's just the expertise of that center.
Thank you so much. I want to let the patients know who are attending virtually that we have your questions. We don't have time to answer them, but what we will do is put the questions together for the panel and have them answer them, and then we will post them on the website. So there's a lot of neoadjuvant, there's a lot of different questions the patients have. So be patient, we'll get those on the website as quickly as we can.
Excellent panel and excellent questions. Thank you, everyone. We're going to break now and go to the clinical trial poster session, which is in the meal room. So this is your opportunity to go ask questions about the clinical trials that are being presented. And thank you, panel. That was amazing so much. Thank you.